thank you everyone for joining us for day 2 of the second annual ALGSA roundtable event. We are, there's a great benefit in having to be forced into a more virtual, way of carrying on business, and we're grateful to have the opportunity to, do this event virtually, and also, learn and improve our skills with our Zoom with great individuals like you. We are blessed to have all of you here. We're so grateful. The speakers yesterday, everyone who talked and interacted, the families who came, the families who presented, were all captivating and amazing. So thank you all so much for joining us for the second day. We are really thrilled about today's recap and what that really means for us and how we did it at the symposium. We'll just do a very brief recap over every session, and then we'll open up the discussion and see if we can't come up with some action plans or ideas, and I'll let Cher go into that a little bit more. So Cher, go right ahead.
Okay. Just a couple of things. We are recording again today. Just wanted to make you aware of that. And today is not a mute day. Today is a discussion day. So as long as there's no one presenting, let's all just, chat about some of these action items that Roberta mentioned. Just a quick little overview of today. So we've tried to break it down, each section, into identifying the main challenge or challenges within each section. So sections being nutrition, itch, bone pain, emotional health, and cardiac concerns. So we want to just recap the challenges that we talked about yesterday, and then go through, like Roberta said, some action items. Action items broken down in also a couple different sections. Some resources like we talked about yesterday. What do we need? What does the Alliance need to provide families and physicians? Any resources that we need to provide? What interactive opportunities there are to further try to meet those challenges, and then also potential areas of future research focus. We're going to try to just get through those 3 things within each topic if possible. And that'll give us a starting point for some future work. We are going to start this morning, though, with Dr. Kamath and also Shannon Vandrell from Sick Kids to talk about the GALA study. Did Dr. Kamath come on? I didn't see. Okay.
We could move into the first.
Yeah, you want to go ahead and let's go ahead and do that. So Dr. Looms and Stephanie are both here. So for each section, if Stephanie. So if Stephanie, Tara, Shammy, and Roberta, if you could introduce the section and then just give just like a quick couple sentence recap for those that might not have been on yesterday about what we heard, and then work with the specialists to kind of go through those action items. I think that would be great. So I'm going to turn it over to you, Stephanie Perry, to talk nutrition.
Awesome. My coffee has not kicked in, so today I'll be much slower. So Dr. Looms and I talked about nutrition, and we talked about some of the struggles around specifically individuals with ALGSA, and from the vitamin deficiency to the caloric intake, and trying to fatten these babies up for multiple reasons. And we discussed some of the drawbacks to that challenging infancy toddler period of being like the excessive vomiting, NG tubes, G tubes, sometimes kind of a Russian roulette of trying different formulas, and then even just the developmental milestones that can get disrupted whenever it comes to feeding, and the impact of that and how long it can drag out and what that looks like. Did I miss anything?
No, I think you covered it.
was good. That was good. And I know, Dr. Looms, you also sent in some, or sent over this morning some additional kind of action items maybe. Can you kind of talk to us about the resources that you, from your perspective, think that we could provide, and then also maybe some opportunities for interactive things and the potential research? I know you mentioned yesterday a couple of really great research opportunities, if we can talk about those too.
Yeah, so you guys had sent around some information this morning as well. And one idea that you had was a focused webinar sort of platform to delve down a little bit deeper into some of these concerns that people have, where there could be a panel of speakers and from different areas. So of course, GI, hepatology, but then dietitian, as well as maybe someone who's trained in nutrition, somebody who's a feeding specialist, and potentially a behavioral psychologist who could help with some of the feeding aversion issues that people encounter. So maybe kind of putting all of those people together and having a short presentations with open discussion and questions from families would be useful. I know that the message boards are probably very helpful because, you know, like we heard yesterday with the pool noodles, sometimes there's some innovative ideas that people come up with that they can share among themselves, and that's very valuable to families to hear from other people who are walking in their shoes and going through the same challenges, or have already kind of gotten past that difficult time and moved on to something different. So that I think could be very helpful if we could set up something like that through the Alliance.
And I haven't responded to all the emails. Oh, sorry.
Yesterday or 2 days ago from NASP again, which I think you guys publicized as well and was probably pretty good. I'm sure that was very good, but maybe something more focused just to the ALGSA community would be really helpful.
And then I was saying I haven't responded to all the emails yet because apparently you people don't sleep. But I was thinking like on our actual ALGSA's, you know, not necessarily the Facebook page, because I know that can get kind of messy with all the new algorithms and stuff, but like on our actual website, even if there was just like a quick tab on kind of feeding 101 or, you know, feeding tips and tricks, that way whenever people do comment or pose the question of, you know, my doctor's talking about changing my child or putting them on formula and we're trying breastfeeding and I'm concerned, and, you know, I think a lot of people just want kind of reassurance that their doctors are doing the right thing and that they're doing the right thing. And, you know, it can be very, especially in those kind of young days, it can be very disheartening to have every kind of hope and dream and thing that you thought was going to happen with your baby kind of ripped out from under you, starting with breastfeeding. I mean, I breastfed Emma very successfully, and so I was like, woohoo, I got this. Like, that'll be one thing that this will be great. And it just never happened. So even if there was just like kind of a, I don't know, quick and dirty type of like, you know, progesterone, very common to be having your kid put on. NG tube, very common to have. It's just something not scary, but just if your doctor suggests this, that's kind of common. You know what I mean? Like just to, I guess, kind of ease people that, you know, my doctor's wanting to switch this or my doctor's wanting to do this. And that way, whenever people are kind of commenting on Facebook and stuff, we can always just kind of send them that link and be like, you know, here's kind of a quick and dirty of what does that first year frequently, not always, of course, but what does it frequently look like? And it's hard.
Okay, like a Q&A basically, got document.
Yeah, just that they can kind of read over really quickly. And I don't even think it needs to include like, you know, here's my specific story or anything like that. Just, you know, like common formulas, the Alimentum and the progestamil, typical, you know, challenges. Breastfeeding may not work very well. You may have to supplement. Just kind of that way someone can read it and be like, oh, okay. Like, so this is the reality and this is what we, you know, may need to do.
Yeah. Yeah, I love the 101s, you know, for especially for new families getting started in so many of these sections.
Yes.
Roberta, real quick before we move on from the resources, can we just talk a little bit about how, you know, I was not around when the message board was around, but I hear great things about it. And if we're moving kind of back to that, you know, we have that love-hate with Facebook. You know, communication is really becoming difficult for us, relying on social media. So can we just kind of talk about how that might work a little bit, since we have so many families on here?
You know, a message board is great because the information doesn't get buried the way it does on social media. And when it doesn't get buried, families can scroll through and see things easier. And one of the things that we talked about is, you know, we have a new website that we're going to be rolling out, and we are going to be putting a back end on that website where families can log in and chat, and as well as, let me let someone in there, as well as hopefully have some kind of message board like that where people can scroll through and find the topics easily. You know, we have our awareness support page, and you can search that, but it is so difficult to search, and families, especially if they are on their mobile, they can't tap into those topics. It's extremely difficult. So, you know, a couple of things that we had talked about with, for example, a message board, but also on the back end of the website, potentially doing some moderated support groups on these topics with professionals in this area. So kind of like what, you know, Dr. Looms is talking about, getting those, tap into those professionals. And if we did even a monthly or, you know, quarterly support group with a moderated platform and with these professionals, it might be an interesting, you know, something that the families tap into.
Yeah. And we've even had, Dr. Fussner that was on yesterday, you know, I know that she and her team are willing to also even maybe be able to be on standby to help us answer questions. You know, we want to be really careful that we don't put out information that obviously that we're not qualified to put out there, but you know, she was really excited to kind of help us, you know, answer some of those questions on an ongoing basis. And I think we can find a nutritionist and, you know, several that could help us do that.
And I think with some of the providers, just reaching out to families, because like with what I do for work, I have an OT that specializes in feeding on my team, like, and she worked with Bryce. So a lot of us have those connections, whether it's, you know, through the hospital or things like that. So that may just be something that we kind of piecemeal a little bit together, just to, you know, pool our resources.
Right.
Something yesterday that Dr. Looms had brought up is there may be an option for nursing support, either at home. And, you know, when Chloe was small, I remember I had nursing support for her when she started her G-tube at home. And then when she broke her leg, I had nursing support come in. But that seems to kind of be going to the wayside a little bit. We don't hear a lot about nursing support at home, but are those options, knowing if those options are still available? Are there certain insurances that accept those or not? You know, weeding through that opportunity would be really great for our families, because we hear a lot of frustration from the families that they just don't understand the options that are out there that they could even, you know, access. And so I really liked that idea, and I'd love to explore what are those options for home care to help.
Well, and I'm curious too, because like in Colorado, and I don't think a whole lot of states have this, but Colorado does. But we have a program where parents, like, that's what Andrew does. So Andrew took the CNA class after Bryce was born, and then whenever Bryce needed to be put on an Inchi tube, Bryce then qualified for CNA hours at home. And so Andrew is his at-home CNA, so he gets paid to take, like, he bills for Bryce, I think 7 hours a day or 6 hours a day or something like that. And that was almost, I mean, it was a huge blessing, and it was a blessing in multiple ways, because then he, like, one of us was going to have to stay home with that craziness of that, those first couple of years and stuff like that. And so now Andrew's home, but he still gets paid through Medicaid through that. And it's a incredible program, and it's been a lifesaver for us, but I don't think many states have that option, but it may be something too to kind of look into as well.
And there are options through public school systems where when children are injured or cannot come to school, that the school can send someone to their home. And I think understanding those options too will be really
Or right now it's probably more virtual. But
I think there's a lot of variability in between states and between different insurance companies, but locally I think people should be encouraged to reach out to a social worker or a case manager, at their home center, because they really are so familiar with all of the different options that are available and can help people access things that they didn't even know were there sometimes.
So maybe a resource guide then of who someone could connect to, and not specific for community, but just,
Yeah, I think it's helpful to have that input. Our GI social workers in our division are very engaged, and they help a lot of our families with accessing these resources, because really we as physicians are not as familiar either with all the things that are out there.
Right.
But the social workers are really knowledgeable.
Okay.
It changes so frequently.
I think, Kim, do you have a question?
Oh, well, I had a couple of
Jump in.
Dr. Looms, you mentioned the NASPGHAN nutrition webinar. I was wondering if there were any families that had actually dialed into it. I dialed into it and I found the content in the first half of it to be very technical for a medical audience. And so I was wondering, you already, as parents of children with rare diseases, have a high degree of medical literacy. Is that information still accessible to you, or as a mom, what I find helpful is when I would read through these parenting things and they tell me, so at 9 a.m., this is exactly what you need to do. And at 9:30, you need to, make them active, and here are the 3 things that they could do. And these are the resources you can use. It's very directive. And so I wasn't sure if that was helpful. That medical information is helpful because your children are medically complicated and have complex nutritional needs, or if it's really, what do I need to do at what time, and how do I know something is going off course?
Yeah, if you're asking specifically about the NASPGHAN webinar, I didn't actually, I wasn't able to join it, so I didn't see the presentations. I knew that it was partly for medical professionals and partly directed to families, so we had just let Roberta and Cher know that it was happening, and I think they put the notice out there, but I wasn't sure exactly how technical those presentations were going to be. And I agree, sometimes there may not be as much to take away on an individual basis from those kind of talks.
Yeah. Well, and I think that Kim, this happens at 9 o'clock and this happens at 9:30, and here are the 3 things to facilitate it. It's so hard with, the kind of pressure that the families are under with, like we talked about yesterday, the pressure to ensure that they get these calories it's an overwhelming stress that we hear so often. And then waking up in the middle of the night to check the tube, it doesn't really fit into a box, which is what's, ALGSA is so variable, of course. And so because it doesn't fit into a box, it's difficult, to really kind of help people through it, because every child's so different when it comes to this.
I think it's really important too that we really, with our assistance program, we've had tremendous success with the assistance program, guys. It's been unbelievable. And I think there's a piece of this that we don't consider in this assistance is, we have families like, David talks on the Hilltop about how vitamins just aren't covered, and, families are paying so much out of pocket for supplementation. And, is there something with this assistance program that we can open up and start covering some of these needs as well as if there is an out-of-pocket expense for a home nurse for even 2 or 3 weeks, could it be something that we really include in our assistance program as well, to beef up that amount that we'll give and cover it?
Mhm.
That was another question I had, and perhaps the 9 o'clock, 9:30 thing was a bad example, but I guess what I was more thinking is, are there guardrails that would be beneficial, or a way to organize information that is, a resource that's usable? When you're talking about out-of-pocket expenses that families are responsible for these supplements, do you have an idea of how much families pay?
Oh, Dr. Piccoli could go even deeper on that.
Just tell it, just vitamin D. Just vitamin D.
It depends what you're on, what state you're in, what your insurance company is willing to pay for, and what your copays are. But it's easily thousands of dollars a year. Sometimes it could be $1,000 a month. So,
And then God forbid you buy it all and then you have to switch, or they give you pills and you have an infant and then they have to reorder it. It gets very expensive and very frustrating so quickly.
Do you have out-of-pocket expenses, Stephanie?
We did before, because Bryce wasn't on Medicaid until he was like 7 months old or whatever. So at the beginning we had a lot of out-of-pocket expenses and things. And yeah, it was the vitamins. And then it's hard to even find them, like, because the compound's only like one pharmacy in our entire, and I live in a decent, Colorado Springs isn't, some little podunk rural place, but there's only one pharmacy that does any kind of compounds. And so then there's the gas aspect too. We drive about 25 minutes, which isn't terrible, but when you're really stretching the dollars, 25 extra minutes there and back drive time, that's gas, and it gets very, very costly very quickly.
Do any of the other families on have out-of-pocket expenses for medications?
Well, we were paying for everything except for vitamin K out of pocket. And we were also paying 50% for formula, which could easily add up to thousands of dollars.
Mm-hmm.
yeah, the unfortunate thing with these is that, 30 years ago, a lot of these medicines were dirt cheap, and they're almost the same medicine.
Mm-hmm.
And so now the price of some of those, like the price of vitamin K, is absolutely prohibitive on a day-by-day basis.
Mm-hmm.
We have some patients where we flipped to parenteral shots in the pediatrician's office because the family cannot possibly pay for vitamin K, and it's backwards because the shot is covered, but the pill is not. And then, as Stephanie said, if you go to a compounding pharmacy, they can, and sometimes do, charge absolutely anything they want. So they might take a $3 pill and charge you $300 for it. And, so we talked yesterday about, the different advantages of different medications. Clearly, you need something that goes into the patient, and sometimes something that bypasses taste. And so even a number of Medicaids will not cover compounding pharmacies now. So, sometimes there is the advantage of saying, okay, I'm going to take this medicine home. Urso. Does it make a difference if you get it made up as a liquid, or if you take the tablet and grind it up in a mortar and pestle, scrape it up, and, it costs you 30 cents instead of, $6. So I think sometimes you have to be creative about those things, but there clearly are times where people ration the medicines their kids really need, because they're just prohibitive. And some, like small corporate plans, where you're kind of self-insured, they just will never budge. But sometimes you go straight to the company, and, I won't say what meds, but we've had a number of different meds delivered to families. Maybe they give you only a month's worth. Maybe it's, a one-time thing. But if you have hardship and make a good plea, it doesn't really, the cost to those companies compared to the charge, there's a wide margin there, and sometimes you can get that to help out. I think Medicaid, you know, as Stephanie said, Medicaid as a secondary, Medicaid as a primary, WIC if it works in your area, claim critical malnutrition. I mean, every kid with ALGSA has critical malnutrition. The minute you put that on, you go into a little bit different category. And if your letter also says, look, you're not setting a precedent, you will never have another plea for an ALGSA patient, you know, within your insurance payer or whatever. They don't know what it is. They don't know what it means. And usually it gets denied, not by a physician, but by someone who looks at page 42 and says, no, we don't cover nutritionals, not negotiable. But you always appeal, you know, and then sometimes, like, you know, call your congressman, you know, definitely get your physician to write a letter.
Or the nutritionist. That's what we had to do for Bryce, because Medicaid didn't want to pay, or he was on CHP at the time, which is like the bump below Medicaid or whatever, and they don't cover nutrition. And he had switched to Kate Farms, which is extremely expensive. And so I called and raised hell, and I was like, no, he needs it. He's failure to thrive, And I ended up having the nutritionist send her whole like nutritional evaluation and all that kind of stuff. And then they finally conceded. So, but people don't know that they can advocate like that, because you feel like you're just complaining. But that's what insurance is there for. And that's the whole point. And yeah, if you're going through 3 or 4 different formulas and everything else, that racks up in itself. Like, but if a lot of times if you call the specific formula maker and ask for samples, they'll send you a couple of cans. And I mean, there are some workarounds, but it takes a lot of work.
So the ALGSA, we are just developing an ALGS access program, and that access program started on the heels of having interaction with a Bolivian family who could not access ursodiol. Shami, our lovely Shami, has some experience in India working with Ordi, dealing with medication access across international lines, or trying to, you know, make sure that families can get it there. And through some research, we were able to discover that there's a manufacturer in Argentina and Peru. And then we did have a discussion with some Miram folks who, thank you, Chris Peets, for, you know, kind of reaching out to someone he knew as far as helping us figure out what some next steps were going to be. And so that program is, once we started this and Shami had the idea, maybe we could call it ALGS Access, I was sitting on it one day and I thought, you know, there's so many more things that this program could cover. You know, we write letters for individuals who are denied Social Security. We write support letters for that, as well as insurance denials. And I think that if we had, you know, I'm just winging it when I write this letter for insurance denial. I'm just putting in as much support and documentation as I can, but I would really like to see if we could put kind of a boilerplate, you know, a boilerplate overall discussion, and then I can plop in the personal pieces in this letter to make a very robust support letter for families with these denials for nutrition and supplements. Is that something that, you know, Dr. Looms, that you think we could pull together? Just a template, maybe a real good template on support?
Yeah, I think that's very doable.
Okay.
And
I think the hard part.
Oh, sorry, go ahead.
Oh, I was going to say, I think one of the hard parts, I know, especially with the insurance side, is that the wording matters so much.
Mm-hmm.
Like Dr. Piccoli said, you have to like specifically say severe malnutrition or, you know, whatever. And so any of those like little key words or phrases that we know kind of get the ball moving. Because if you sent the exact same letter and just didn't have that piece in there, then it would get denied. But if you sent the letter with that specific wording in there. And, you know, there's just all those little tips and tricks that I don't outright know. I mean, I'm assuming someone who sits there and denies things all day would know.
Well, maybe it's a combination of advocating, you know, encouraging them to get a support letter from their physician and then have a support letter from the ALGSA as well.
Mm-hmm.
Okay.
Dr. Piccoli, really quickly, I try to quote you all the time. You know, it goes beyond the supplemental nutrition. It also goes to vitamins. And you have done such a good job of explaining vitamin D levels. Just for those that maybe are new to the community on here, can you kind of tell us, you know, what a typical healthy child might need versus what an ALGSA child needs every day? And the insurance companies are like, why do you don't need this, it has to be a typo.
50,000 units.
To Stephanie, since this is your session, give me a time limit.
No, I'm just kidding. Take it
So
away.
there are a lot of natural vitamin Ds. There's vitamin D, and then there are really two big classes of pharmacological vitamin Ds. There are the ones that are 25-hydroxy vitamin D, and then there's the fully activated Go Live grenade vitamin D, which is 1,25 dihydroxy vitamin D, which is called calcitriol. So the regular vitamin D, the question, how much do you need? The question is, you do it totally by levels, and you have to get the levels to a certain level. So the amounts that some people need are extraordinary. And the units of different pills go, or drops, go from things that are 1,000 per pill to 50,000 per pill. So that shows you the differences for different people. It's extraordinary. So for a lot of our liquid preps, they're like 8,000 units per ml, but for a lot of diseases, you just get like a drop. They actually measure the prescription in drops rather than units. So the dose sometimes is extraordinary, and the cost of the liquids is always extraordinary. And the amount of D in the mixed preparations is not high enough for ALGSA syndrome compared to some of the diseases that those were made for. So if you have something that has all the fat-soluble vitamins, for something like ALGSA, it might have too much vitamin A and too little vitamin D and E. So a lot of centers do them individually, which isn't really more expensive, but you couldn't possibly give the same dose of these combination drops because the vitamin A can be toxic in high dose, and it causes liver fibrosis, liver damage, and like, why would you do that? Why would you take that as a risk? Also, it's the easiest one to absorb. So a lot of kids with ALGSA syndrome have high vitamin A's. So sometimes when we can't get regular vitamin D to work, or we can't afford it, we go to the fancy kind of vitamin D. It bypasses a regulatory step, so you have to pay attention to it. And when people order a vitamin D level, they don't measure the active one, they measure the other one. So you have to, your physician or whoever's ordering your labs has to order the 1,25 to be assayed, not the 25, which if you just write vitamin D level, you get this. On the other hand, this one works great. It's always covered by prescription because it's used in renal failure patients all the time. In some centers, your nephrologist will order it rather than your gastroenterologist. I think we're quite comfortable with it, but sometimes people say like, I don't want to do that one. And that one can be toxic if you get way too high. Time.
I have another suggestion too. Last year, or well, early 2019, late 2018, the National PKU Alliance really went on a mission to advocate to their, representatives, state representatives, and so on, to co-sponsor the Medical Nutrition Equity Act, HR 2105. And I remember talking to someone at the PKU Alliance, and they had the feeling that ALGSA syndrome would be considered one of the diseases that would be under the Medical Nutrition Equity Act. Now, Cher and I had a call with NORD to see if we could get some help on how to kind of move forward with advocating, you know, to get on board with this Medical Nutrition Act. And we really hit walls all over. You know, I wonder if we could figure out how to really understand this Medical Nutrition Act, and if we're not a part of it or not under the umbrella of it, how could we force our way in? Force our way in there, because it covers for PKU, it covers the nutrition that they need and the vitamins as well.
Dr. Looms, can you touch on again those two areas of potential research that you talked on yesterday, the body composition, resting energy, and then also the hyperlipidemia?
Yeah, I just was thinking this morning that maybe in terms of nutrition research for ALGSA syndrome and also other types of chronic cholestatic liver disease in pediatrics, we may have an opportunity for training or to engage some of our colleagues who are actually boarded in nutrition. You know, we as hepatologists have a strong interest in making sure that we optimize nutrition in our patients, but we don't actually have all the knowledge of all the micronutrients and the everything that our nutrition colleagues have. So I feel like maybe we have an opportunity to partner with them, or maybe Dr. Piccoli, we could try to engage some of our upcoming nutrition fellows in doing research in chronic liver disease and applying their nutrition knowledge to that. So I think that's something we could definitely think about in the future, and how to augment clinical research in nutrition and in pediatric liver disease, including Alagille syndrome. And then the other thought that we had talked about yesterday was the idea of statins in Alagille syndrome for hyperlipidemia, for treatment of xanthomas, and there is some emerging literature about the use of statins in chronic liver disease. So that's something that we're actively thinking about, but there's nothing ongoing right now. But that's something for the future.
The way to get included is to have each person figure out, or do we want to do this at the state level, which matters, or the national level, and who your rep is, and you know, your representative. You can try your senator. It's not necessarily as good. It has to be the person in your district. It doesn't, like, they don't care one bit if, like, I call Colorado Springs, because I don't count to them. I'm a problem. But that really can work. And when they think that they're doing good and it doesn't cost much, they're happy to sign on. So I think if you got, you know, 5 or 10 people from across the country to look at this and say, you know, yeah, this makes, I'm going to do this, you know, and sometimes they have a nice little article or something on their website. That really works. I think we could also ask, I think every hospital has a lobbyist, particularly every children's hospital, because the children's hospitals kind of get creamed from the point of view of federal money for healthcare, because many things are pegged to Medicare, not Medicaid, because Medicaid is state. So, you know, we could ask our lobbyist if he could have one of, you know, his people look at this and see, you know, and if you could get, you know, 5 different children's hospitals to sort of sign on and push this, that would be a big impetus as well.
That was going to be my question: is can patients talk to the lobbyist, or is that's a provider only kind of access point?
You know, so it depends. Lobbyists all get paid, and they mostly talk to the people who pay them. Hate to say it.
All right.
But your representative is paid by you, right?
Right.
So theoretically, they represent you. I don't know, maybe that's a little Pollyannish, but that's what they're supposed to do.
And moving on.
Yeah.
Okay, does anyone have anything else to add to any of this? Feel free to, today's the day to really chat. So feel free to, if you have suggestions or comments or questions, please feel free to just jump in there before we move on. Does anyone have anything? Dr. Looms, do you have anything else to add for the group right now?
No, I think that covers it, but we'll be happy to hear any other comments that come up later.
Okay. All right.
Thank you for everything.
Stephanie, thank you also for sharing yesterday. We've already talked to people about the pool noodle, so thank you for that. Dr. Kamath, do you have time for your presentation, or are we going to send that over to Shannon?
No, I think I can do it. That's absolutely fine. Thank you.
Okay.
Okay, good morning, everybody. So I've been listening to all the great conversation that's been going on, and we're going to change tack a little bit now and talk about the GALA study, the Global ALGSA Alliance study. And many people will already be aware of this initiative that we started a couple of years ago, but I think it's nice to give people an update on how things have been going and where we have moved to. Sorry, I just need to, there we go. So these are my disclosures, the same as I had yesterday. And so first of all, just for people who are not aware of what GALA is, GALA is a global initiative to create an international research database of clinical, genetic, and laboratory data for ALGSA syndrome. And why do we need it? Because typically what's happened in the research arena is that single sites, or maybe a few sites get together, a few hospitals get together and they publish their data. And we realize that what we really need to do is to bring, because this is a rare disease, we need to bring data collection and analysis together from many, many more centers, and preferably the whole world if we can. And so what we're doing is we're capturing database from the world, from any site really, from children and young adults from birth to 30 years of age. And really we're focusing on the liver, but also beyond the liver. So really thinking about heart, kidney, vascular involvement, growth, all the issues that we're discussing during this webinar that are so important to the community. So as I started to allude to, why is it needed? So as I mentioned, some of the older studies came from single sites, because some of them are really quite old now, 20 years old, more than 20 years old. And at the time when those studies were done, there wasn't genetic testing to confirm a clinical diagnosis. Also, a lot of the papers that even come out now really focus on ALGSA syndrome patients with mostly liver disease. And the heart, kidney, and vascular involvement, in our opinion, is not as well characterized as it could be. The other area that we think that is a gap is that there's limited research in adolescents and young adults with ALGSA syndrome. And to be honest, there's limited research in older adults as well, but that's almost too much for us to take on at this point. But we thought that at least we could really focus on thinking about adolescents and young adults. So really, getting all of this off the ground couldn't have been possible without the Alliance. It has been so crucial in every step of setting up GALA, because all those things that I just described as what we're trying to do, where we think the gaps are, were all highlighted to us and for us by the Alliance, and of course, led by Roberta and Sher, really helping us to think. They've been there from every step of the way in terms of helping us identify the gaps, but even going into details and looking at each of our case report forms, every data element that we've chosen to collect. And this is even before we started to say, this makes sense, this doesn't make sense, have you thought about this, have you thought about that? And this goes beyond, this is real, what I would say, it's a collaboration, and it's a real sort of iterative process where we say, this is what we think we should collect, and Cher Roberta would say to us, oh no, but have you thought about this, and have you thought about this? And this is really the key element of bringing the patient's voice to the forefront and to make it intertwined with our research. In addition, we've had fantastic partnership from both Miriam and Alvareo in terms of academic discussions about what's important to collect in GALA, as in what can we collect in GALA that can help inform clinical trials. And that is so crucial to make the clinical trials work to the best that they can be. Because even though we don't do the clinical trials within GALA, what we're doing is we're collecting data on patients with ALGS syndrome so that we can then tell Miriam and Alvareo, look, this is what happens to the lab values in a large group of patients with ALGS syndrome, so that when they can then compare that data, that natural history data, to patients that are in trials. So this is really important, and it's also important for regulatory bodies like the FDA. So you can see that there's a huge amount of value to having a database like this. So the specific aims of the study are, number one, to determine the global prevalence and geographic distribution of ALGS syndrome, to really understand what happens across the world. I think much of the data is biased towards North America, some in the UK, but we thought it's important to try and get a broader understanding of ALGS syndrome in the world. We want to characterize natural history and long-term outcomes. We want to know what really happens to patients with ALGS syndrome, and where do their outcomes, what happens to them in terms of liver disease outcomes, heart disease outcomes, all the different organ systems. We want to understand what that disease actually looks like in the heart, kidney, and vasculature, which to date we think has been relatively understudied. And a big study, which is relevant to what we were talking about nutrition earlier, is that we know that we need a validated ALGS-specific growth curve, and that's an ongoing an area of study for us as well. So how does GALA work as an actual study? We thought it's important for our community to really understand how is it different to a registry, how is it different to a clinical trial, just so that people really understand what happens. So basically, a hospital, or a site, we can call it a site or a hospital, interchangeable terms, they have to get ethical approval at their hospital to participate in this study. So that's actually the first step of where it goes, because you can't do this type of research study without ethical approval. So it has to start with the physician or the hospital where your child is cared for. They have to start the process. And then the participating hospital review the medical records of all the patients at their center, and they follow, they use the data elements that we've asked them to look for in their charts, and they enter it into a secure database, which is called REDCap, and that they can access that database from their site. So they're not sending us anything at Sick Kids, or they are just collecting data at their site, and they're putting it into this very secure, confidential database. We then manage that database here at Sick Kids and the University of Toronto. We can consider us a sort of data coordinating center where we receive all of this through the database, and then we can pull all the data from all the hospitals around the world that are sending the information, and we can do the analyses. And then finally, when we pull all these data together and start identifying new things, making new discoveries, in the physicians and the scientists in the community at the other hospitals and others in the community can work with us collaboratively to prepare scientific material for presentation at meetings, for manuscripts, and we can really discuss the science as well. But we're not discussing individual patient data, we're discussing all the pooled data from all the hospitals. So how is it different to a patient registry? A research database is different from a registry because in a database, only a hospital that has had ethical approval at their site can submit data. And it's done this way to ensure anonymity, data integrity, and lawful transfer of patient data. As physicians, we cannot just transfer your records from one institution to the other without getting ethical approval at our site. And because there's not a registry, in a registry, patients themselves can enter their data. We can't do that. We're a research database, so it's a little bit different. So we unfortunately cannot accept medical records from patients. I say unfortunately, I shouldn't say unfortunately. There's a strength in not doing it directly because we can ensure anonymity and data integrity. It just has a different role to a patient registry. I'm not saying one is better than the other. I think it's just good to clarify that they're two different types of things and they have different roles. But GALA is most definitely a research database. So we only started a couple of years ago, 2018, and these are the countries right now where there are hospitals who have already sent us data. We have 84 participating centers in 35 countries. So we are thrilled that this has been possible. This has been possible because of our partnerships with GALA and Mirum and Alvareo. We started with GALA with ALGSA Alliance, Mirum, and Alvareo, and with the participation of all our investigators across the world. And it's been really exciting, actually, to have investigators that we've never heard of before. I mean, I know the pediatric hepatologists, gastroenterologists in North America, and many of them in Europe. But we're now collaborating with people in South Africa and in New Zealand and in Brazil. And we are really are going to be able to expand our understanding of ALGS syndrome. So we have 84 hospitals, as I said there. And I think we're going to say, as of September, the GALA database now houses information on more than 1,500 ALGS syndrome patients. So this is beyond our imagination that it would have been this successful. We're so excited. Just to give everybody a reference, probably the largest ALGS syndrome papers that have been published have typically described information on a couple of hundred patients. This is greater than 1,500. This is what we already have after 2 years, and it's an unbelievable opportunity to really learn new things about ALGS syndrome. Just to give you an idea of what type of data we collect from all of these centers, it's all written up here. We're talking about liver biopsies, how many patients go to liver transplantation, asking about medications that treat itch. We're talking about all kinds of heart involvement, and of course, that information we will be sending over to Dr. Feinstein at Stanford to help us analyze that. We're not the experts at doing that. We're interested in kidney involvement. We're extremely interested in vascular involvement, and we're going to be eventually reviewing, right now we're going to review reports of MRIs and abdominal MRIs and CT scans, but eventually what we would love to do is look at discs or look at actual reports themselves, and then height and weight data and laboratory data, pregnancy data, and really it's a pretty comprehensive database that we're asking for. So people who have heard us talk about GALA before know that none of GALA is possible without Shannon. Shannon is the project manager for the study. She really runs the whole show of GALA. She also runs me a lot of the time, and she's very effective in doing both of those things. And because of the generosity of our funding partners, just this year we've been able to hire 2 more people. So we have Ali and Michaela, who are both now on board working exclusively on GALA and supporting Shannon in the work that we do. So this is great. We've gone from this being an idea to now having myself and then 3 full-time people dedicated to cleaning, coordinating, analyzing all of these data. The scientific committee is up here. Many of these are familiar faces to you, but this is really a group of the people that we think are the most dedicated clinician scientists and investigators who can really help us think about how to run GALA and to analyze these data very effectively. I want to point out Bettina Hansen, who's our senior biostatistician. She's probably the premier statistician that works with liver diseases in the world. She works with many of the adult consortia also in analyzing liver disease data, and so we're really grateful to have her with us. And I think I also want to highlight that we have got representation from across the world. So Emmanuel Gonzalez, who's done some fantastic work in ALGS syndrome and PFIC and in the clinical trials from France. Dr. Piccoli, of course, who we all know is our true leader. Richard Thompson from King's, Henkian from the Netherlands, and also very happy to have Professor Wang from China in Fudan, who has been able to give us several hundred patients with ALGS syndrome into the GALA database. So in order to reflect the global database, you need global investigators, and that's what I think we've achieved with this scientific committee. So where are we going with all of this? We have successfully presented in the last, so we only started in 2018, it's now 2020. We've already had 6 very successful Congress abstracts, some oral presentations, created a lot of excitement in the community, and we're now working on our first manuscript. And we're also going to develop, hopefully be able to develop evidence-based guidelines based on those analyses to inform patient care, thinking about when patients should have MRIs, thinking about growth and other guidelines to really lead the community. How can our families get involved? Being aware of it is really important. But if you think that your healthcare, you can ask your physician, are you involved with GALA? And if you're not, would be to share the email address. This is the email address, gala.study@sickkids.ca. It's pretty easy to give that to your physician or to your healthcare team and say, please contact the GALA research team and please get involved, because as I've said, you can advocate with your physicians, and then your physicians can get involved in the process that we've described. Here's just an acknowledgement of all our investigators, huge number of people. And again, thank you again to our partners that have helped us. And with that, I unfortunately have to step off to another call. I'm really sorry, but Shannon will be available for questions, if that's okay.
Wow, this is amazing. Amazing.
Yeah, it's a group effort, and Roberta Share the Alliance, you know, has been up there right from the beginning. So I actually remarkably have to get on a call about the EAP program for Alagille syndrome. So I'm not feeling guilty, because I'm going to do a bit more advocacy for our community, and I'm coming back. So forgive me, but I'm going to hand over to Shannon, and I will be back.
Perfect. Thank you so much, Vanita.
Bye-bye.
We're going to move right into bone pain, and Shami is going to recap that, and then Dr. Piccoli and Shami will talk to us about some of those action items. So I'm going to turn it over to you, Shami.
Hi, everyone. I have to say, I learned so much from Dr. Piccoli's presentation, so many things that I just didn't even know, which kind of contextualized what I go through and what I've heard other patients go through. So thank you so much, Dr. Piccoli, from me and from so many patients who are going to watch this video later on. We essentially went through what it means for daily living and at different stages of your life, what it prevents you from doing, what it makes you go through as a child and as an adult, with Hannah's presentation about her son Damien. I learned about abdominal pain, which is something that I personally have never gone through. I went through the aspects of financial and mental health and, you know, keeping a job and that kind of thing. And of course, Dr. Piccoli's presentation dissected every aspect of vitamins, and I learned the word tuberculate, which I'm impressed that I remember. But what we identified essentially through all three presentations was the fact that people don't know who to go to when they're in pain, and they don't think that it's something that necessarily merits a separate specialization or going to a special doctor for it. So like the survey results pointed out, only 3% are actually, you know, seeing a specialist for managing pain, which surprised even me. I mean, I thought that more number of, you know, adults would go in for physiotherapy and things, which is something that I've personally tried. So in terms of an action item and what we can do, I think as a patient, one thing that I would have liked to hear is, it's okay to be in pain. Firstly, you're not insane. And secondly, where do I go now that I've recognized the areas that I'm in pain? And so clubbing that kind of affirmation with Dr. Piccoli's slides on who are the specialties and, you know, what kind of questions to ask them, how do you tell them that you need a multimodal pain management drug, as well as say physio or maybe even cognitive behavioral therapy, a kind of toolkit that just demystifies this pain aspect, that we can share with doctors that we know, that we can share with families that we know, perhaps like a little tab on the Alagille syndrome page. But that was just something that I thought of. I'm going to ask Dr. Piccoli, what do you think that we could do as an alliance to demystify the medical side of it? I think you're on mute. Dr. Piccoli, you're on mute.
And I just paid you this great compliment. Who can read lips? That was a great summary. So I think that I'm not the biggest expert on social media. I have to say, my kids 30 years ago said I was not allowed on Facebook. And so I think that pulling together the information in one place where people can write in about what types of pain that they have and what has been done is one good part of a resource for people to think about. The list of specialists that I provided yesterday, I mean, for bone, joint, and muscle, I would almost always start with a rheumatologist. And I think they are more accessible by far than an ALGSA specialist, so that most people should be able to get to a pediatric or an adult rheumatologist. I think you could take to them, you know, the list of different things that are potentials. But one of the things I was really struck by yesterday, and so I did my own little low-grade social media, I Googled each of the centers that people who were speaking kind of were associated with. And essentially every one of them has a pain center. And so, you know, I'm looking way over here on this computer, Stanford, Colorado Children's, Lurie Children's, CHOP. Everybody has multi-member teams that deal with chronic pain, which is obviously different than like post-op pain or bone fracture pain, which is much easier to deal with. So I think a key thing is understanding the spectrum of the problems. You know, for instance, Jemmy, you just moved from my screen there to there. The issues that you have, if we totally separated those from ALGSA syndrome, we would say that's a really excellent description of amplified musculoskeletal pain syndrome, or what we call AMPS. And we have an AMPS program that I can almost never get a GI patient into, because there are so many bone and joint patients who go into this program. And you know, when they first came to CHOP, you know, you always have to sort of trust but verify in ways. I didn't really think it was a program that was going to work, but it seemed to have worked where this person came from, Dr. Sherry, who's a rheumatologist. And it's amazing. It doesn't work for everyone, but it works for a lot of people who have terrible multi-system pain. And the, you know, theory on this is that something sets up an increased pain sensitivity, an increased pain response, and it's not always due to a specific disease that can be identified. You know, it's not always a broken bone or an inflamed joint. So I think that summarizing the experiences, finding the right people to do the first look, and thinking about, you know, can we get some, I would say rheumatologists, but it could be other people to be involved at a more broad level. We know a lot of the anatomic issues, but I think we don't have as good of a understanding of the functional disabilities. And I would definitely, you know, I'm a believer in medications for pain control. I'm really a believer in cognitive behavioral therapy and psychology as a part of this. We have an integrative health center at CHOP that does everything from hypnosis to acupuncture, you know, medical nutrition, all those different things. And sometimes 3 different techniques each make you 30% better. No one is magical. And in the end, you're really good. And so I think those were, I was not as aware of the real spectrum of problems. And I think partly a little bit because of the luxury that when the patients I've seen with gout or joint inflammation or destructive bone disease, we send them to the pain team and we send them to the orthopedic surgeons or the rheumatologists. And I think they have great respect for the fact that this is a very complicated disease and they have to think disease specifically as well as general process. You know, back pain is a terrible thing in adults, but back pain in ALGSA syndrome has a lot of other things to think about. We do need, and this is a real deficit, I think, across the country, across the world, because pediatric centers can focus ALGSA syndrome because of the cardiac or the liver abnormalities. There are a lot of centers that have seen 20 or 50 or 100 or more patients. When you go back to your adult people, you'll be like one of the only ALGSA patients who's followed in their transplant center, followed in their cardiac center. You know, it's just that the expertise is not concentrated. And I don't know a good solution for that other than, you know, trying to pull it together and make it easier for clinicians to care for the problems. They have a general idea what to do. They don't have specific content knowledge.
You know, as I heard you kind of summarize the need for a multi-approach to pain management vis-a-vis mental health, physio, medication. For me, what I kind of think of is kind of documenting it so that it kind of filters outside of the US, because in the US you have clear systems. You have, you were talking about Epic, I think it was yesterday, where doctors can see each other's data and things. And most countries outside the US don't have that. So when you kind of try to tell them, okay, pain is a part of ALGS, they're just going to say, okay, but where is the paper or where is the discussion on it? And I was just wondering, with the survey results that we have and with all the expertise on this panel, is there something that we can do that kind of lays it out, and through our networks, we can filter it out, you know, to other countries. We can translate it, we can tell our own physicians, and it can meet it out, because I still go to my pediatric doctors. But when I do need a special consult, they do put me in touch with a adult specialist, and they explain my case. And it's very informal. It's not a set procedure, which is why having a document, or say this video, for example, I'm going to make my doctor watch what you said. That kind of thing would be very, very beneficial for patients outside of the US.
Yeah, so I think the route to get to that would be a survey and a sort of general review. Those are harder to get published in mainstream literature because they aren't as much data driven in a way. But nonetheless, you can get them published and you can have them be a guideline with a small g. A guideline with a capital G is like, this is what medically is the state of the art and you should do. But something that summarizes the experience. I think even just, you know, yesterday we talked about validating pain and the need for pain meds. When you are meeting a practitioner who has no idea how to even Google it, much less, you know, what the specific issues are. So yeah, I think that would be, it would be a really important thing to do.
And how do we include, so something you said yesterday, Dr. Piccoli, that, you know, what did you talked about steroids and how steroids don't really work with ALGSA patients, you know, because of making the bones weak. You know, communicating information like that, just so it's thought about, you know, how's the best way for us to do that, to communicate those things?
Yeah, it might actually be through the people who care the most and who are the most focused, which is the Alliance. So, you know, if you went to a rheumatologist and they knew that bone density was a astronomical problem in ALGSA syndrome. I mean, some of our patients have that DEXA scan be like a -4, which is really as low as we ever see in any disease, lower than cystic fibrosis, lower, you know, than other liver diseases. You know, a rheumatologist would say in a minute, if you have joint inflammation, I will never put you on steroids. because like collapsing the spine would be a high likelihood event, and then probably recovering from spinal surgery would be an extraordinarily difficult event. So they have other tools, just like the pain doctors have a whole group of other medications than, you know, just narcotics. And, you know, so some of those things you could do as general wisdom. You could put them on the Alliance website, but it would be kind of like ask your doctor about.
Right.
Like for a regular patient with ALGSA, I would let them use regular doses of NSAIDs. You know, for someone who has significant kidney disease, I would, you know, not let them use a ton. Regular doses of acetaminophen. You know, I'm not using trade names because whatever, we're not supposed to, but you all know what I'm talking about. You know, regular doses for regular things are okay. You know, it's, I mean, there are some people who like, even for like menstrual periods, will not take any medication because they feel like every medication must be bad. But on the other hand, there are certain you can't make broad rules, because there are clearly some patients where I tell them never NSAIDs. And there are other patients where I tell them never acetaminophen, you know. And interestingly, for a lot of pain, the one that is not much of an issue in ALGSA are the narcotics used correctly, except like if you're on naltrexone, and then you have competing meds, you know. So it's important that somebody's thinking about you specifically, but we could clearly make some ask the doctor if, you know. So, you know, I'm concerned that my spine is not normal and my bone density is not great. Should I really take steroids for X? And that could include, you know, severe poison ivy, much less joint disease.
And maybe even we have to go back a step farther. We learned from the survey that, you know, so many of the young adults especially talk about pain in general terms. They're not sure. Is it joint pain? Is it bone pain? How do you have bone pain? Is it muscular? So I think maybe even helping them zero in on what they are feeling. Shami, I know you can kind of speak to that.
Yeah, no, I mean, the first time that I really tried to dissect what is when my brother, who's studying medicine right now, sat me down and said, when did this start? Like, I've lived with you all this while, and I've never heard you complain of this. And then we kind of broke it down, and he started asking me the questions that a doctor would ask you. And slowly that picked my brain, and I started to document it myself. But as a patient, before I had that conversation, I didn't know the right questions to ask. I didn't know what a nervous pain should sound like, or what a bone pain should sound like, you know, to get the doctor's attention. But having that conversation helped. So how do you recognize what pain it is? That came just because I have a doctor in the family. And it takes time to kind of dissect it and observe it and see what times that it comes in and what it does to you. Like one of the things that Dr. Piccoli mentioned was about
Uh-oh. You froze up, Shami.
Well, so let me jump in then and say, I mean, what Shami said is exactly right, but a rheumatologist, that's what they spend their entire life on. So they know that if your knee hurts, it's a very complicated spot that has a whole bunch of different things that could be wrong and a whole bunch of different things that could be done to make it better. And so it is really good to crystallize what you think is going on, but you have access to a professional where that's really what they do. And you may have a whole bunch of theories and then find out that you tore a meniscus, and that's really what's going on. It has, nothing specifically to do with the individual ALGSA items, So I really think that rheumatologists are a first step to chronic musculoskeletal pain. And the second is to link with their pain management team so that you can feel better as you're doing the things that might make you better.
You also mentioned cognitive therapy to learn to deal with the pain so it doesn't take over your life, you know, while you're getting to the bottom of the cause.
Yeah, it's a little bit learning to deal with it, and it's a little bit to take control of it. And they're a little bit different skills, you know, and so, you know, in something that is much more pervasive is belly pain, which we see, you know, literally 10 or 15,000 visits a year in our division. You can teach people to control it. It's not to ignore it, but it's to control it so that it doesn't accelerate and take over. And those skills are really surprisingly effective. You know, sometimes I use the analogy of the people who, you know, walk on hot coals or walk on nails. You know, you can't walk on hot coals and not get burned. So what is it that they learned that they don't feel that as a pain and they continue to do it? And it's an extreme example, but it is the power of the mind in controlling the generation of symptoms.
Does anyone have thoughts, questions? Feel free to jump in.
I think it's clear there's an emotional support piece to this that needs to be addressed. And I can give one example. We had an adult ALGSA patient who had lost his 27-year-old daughter to ALGSA, and he was suffering from severe back pain to the point where he could not hold down a job. And he had never had genetic testing done because he was in his 50s, and back then they just didn't have it. And what we ended up doing with him is he was treated as a drug addict and could not get any kind of pain management, pain support, any of that. And so his family physician really kind of pushed back on, well, I don't think you have ALGSA syndrome. You know, and he knew he did. His daughter had it, you know, and it passed away. So we got him to have a genetic test done. So he had the proof of the genetic test, and he went back to this doctor, and then the doctor treated him with a little bit more, you know, dignity and respect. Sad situation, happens a lot, especially with the older ALGSA adults. But all these years, and especially since his daughter had died, I think it was about 5 years ago now, his emotional state, due to the pure frustration of having to prove that he had something in order to get relief, was just heartbreaking. He crying on the phone, you know. How can we really bring this to an emotional support piece for these individuals in the community? Because it got to a point where he didn't want any emotional support. He was done, you know. It's hard to break through that once they get to a point where they've been turned away and just beat right down. They don't even want support. And what are the ways that we can encourage that? You know, I don't know. Our support groups are great, but they're not moderated. They're not moderated with professionals that can pull out or change perspective or encourage more. Maybe that's, you know, something we could consider here as well, a monthly support group for pain management with, you know, pain association or something along that lines. I'm not real sure. Yeah. Thoughts on any of that?
Definitely a piece. I mean, that emotional support just is in all of these sections. You know, that's something that is definitely a priority. Before we run out of time on this one, for the investigators that are here, and then also Dr. Piccoli, this is such a broad area with not a lot of research being done. You know, what are some areas where we can kind of maybe focus down and get some interest in? We have a little bit of interest already in bone pain in general research, but how can we target some things? What are the best things to target from your perspectives?
You know, I think the first thing you do is you try to define the problem, and I think that's what you started with this survey. You know, unfortunately, this is not going to be a specific thing like bile duct paucity or proliferation or, you know, the pulmonary artery. This is going to be a very diffuse process with a whole a host of different abnormalities and issues. So I think the first thing to do is to catalog those and to see whether there's not a central cohesive ALGSA expertise that's going to be likely here. It's going to probably be more important to say, if you have back pain, these are the things, but you're going to go to a regular orthopedic surgeon and a regular neurosurgeon, but someone else has now thought about what are the issues that they should be thinking about, they should be looking at. You know, I think for most adults, you're not going to have an ALGSA shoulder, you're going to have a shoulder and you have ALGSA syndrome. So I think defining what are the issues and the problems and separating out the ones that are ALGSA specific versus the cognitive behavioral and the pain management that work for all patients and all syndromes. So only one part is ALGSA specific that puts you into these groups, but these groups are the groups that can take care of you. I think that's really the way pain works. And I think, you know, if you just separated it down into like back pain, there's so many approaches to back pain because none of them work great. You know, it's just, I don't know if anyone's ever like ruptured a disc or anything and gone to 3 different people and you get 3 different opinions, you know. So I think that defining the issues first, figuring out who can help you with which different issues, what are the risks, and then delivering that as content information to everybody who has the issues for them to take to the people who are helping them.
Yesterday, you had mentioned, Dr. Piccoli, on potentially letting patients know that they could maybe get a support letter from their clinician that's aware of ALGSA to just carry with them, you know, if they were to have a pain issue, or maybe even not carry with them, but easily access that, you know, from their chart or their physician's office. Do you think that's something that we could, you know, is there a boilerplate of that? We could create a template just to see if that helps, or what are your thoughts on that? Is that something that doctors would want to get involved with? I know there's a fine line when it comes to, you know, pain medications and advocating, but it's clear that especially the adults, they need some kind of support in that way.
So I think it would work best if it was focused on what part of ALGSA is relevant for what problem. Okay. So a knee problem is totally different than a back problem.
Right.
You know, you could in an hour write a letter about the susceptibilities of the back to destructive and degenerative damage. And that would only matter for people who were having back pain.
Right.
You know, so you could set that up, but broadly understanding ALGSA syndrome probably wouldn't help any of these people. But a little bit, as you said, with like even just the genetic testing, having something significant and systemic validates your concerns for a lot of physicians. Mm-hmm. So, you know, if they don't have any understanding of what you're going through, then like arm pain won't necessarily mean much to them. But if there's something that they have that, sort of says, these are all the issues that the body has been through, can you examine this and think about this and treat this in light of those? That would work. So I think the survey to get some information about, specifically the different abnormalities. I think the generalized musculoskeletal pain almost always goes to pain control teams. And there are many, many people without ALGSA syndrome who have those same problems.
Mm-hmm. Amy, do you have anything?
I did try from yesterday to get a pain or a rheumatologist to get on this call. It might, just like Dr. Fussner, is talking about general principles and applying them to ALGSA. It might really be an advantage, for the next time this is all pulled together, to get 2 rheumatologists and 2 pain control people to think about these things and have, it organized in advance. It doesn't work great to have a liver doctor and a cardiologist talking about chronic pain management, because for the most part, our organs don't hurt that much. There are definitely organs that hurt, but no one has really complained about, I have liver pain.
I would like to just point out that the cardiologist hasn't commented.
I did notice that, but I am going to push it back to you because you've done such a great job. I think all of us have had heartache, so why can't you help us with that?
Chest pain. I do chest pain.
No, heartache. Heartache. It's different. See, you're not being receptive.
There's a reason.
You too. Shami, do you have anything to add at the end, or does anyone have any more comments before we move on?
No, I'm just learning and listening, and there's so much to pick Dr. Piccoli's brain on. I definitely think we need to do more webinars with him. But no, I think, we need more resources, and we could do with some deep study on the survey results that we have.
We learned a lot from you, Shami, also. Don't sell yourself short. We loved hearing about that. And that was a fantastic way to, to present what's going on.
She's with me right now. She's the reason I'm shuffling around so much. It's less said the better.
Yeah. Okay. Thank you, Dr. Piccoli, also, as always. Okay. No breaks. Next up is emotional health, and I think Dr. Quiros is on here, and so I'm going to turn it back over to Roberta.
Okay, yesterday in our emotional health session, Dr. Fussner, Ms. Galamali, and Dr. Quiros all spoke about the need to recognize emotions like guilt and blame, validate feelings, take time for self-care. We shared some a little bit of my personal story as well. And Dr. Quiros, we'll start with you. From that session, what are some takeaways that you felt were tangible or actionable plans we could pull together? And you're muted, by the way.
Thank you. No, I think it was a really, really interesting session. I think this is an area that we found very difficult to talk about. I think is a very sensitive subject, and I think that put us in a little bit of a difficulty at times, because it's hard to recognize that we need help sometimes in the emotional area. It's easier to understand that you need help if you are limping or having pain or you break a bone. But sometimes with emotional area, it is hard to come up come out and say, hey, I need help, because also there's some stigma about it, and we are supposed to handle things, and that's the way we are all being brought up in a way. And I think we have to, it was really good to see that survey that you put together. I think give you an idea where people are on this in regard to how they handling the very, sometimes, you know, with ALGSA, the issue, and we all know this, is the spectrum of the disease. You know, what may apply to one parent may not necessarily apply to the other, because sometimes the heart may be what is kind of more important, taking over in the care of the patient. And I think we recognize some of the issues, obviously, that happens with chronic illness, like the guilt, the blame, the shame. We talk all these different aspects. But I'm wondering if one, there will be here an opportunity, obviously, to get a little bit of more, try to get to understand better, if we can see if there's any specific area. There are areas in common with people with chronic illnesses that you can cover, but there are some other areas that probably, in trying to develop resources for us as a group, like, can we do a survey and try to recognize who has, where people are. You can use that to develop some sort of I don't want to call it pamphlet, but booklet or something that you can have it as a resource of. These are things that you can go through in general with when your child is diagnosed with. We talk about a little bit that initial struggle when you are faced with the diagnosis, sometimes of for in front of you, sometimes is something that you don't quite understand the magnitude of it. At times it may be something like it's just elevated liver enzymes and the liver, some call it stasis, but sometimes you are after that diagnosis you are talking about, you know, this is after a open heart surgery. Then I think we need to potentially do those things. These are things that you can face in that process. And the other part to it will be, I think, important to develop some sort of a support networking. I think now distances are shortened by virtual. No, we are all learning, even though I have some difficulties to log in today on Zoom, but I think we all become experts in doing this. And I think talking to someone in Washington state is not as, and face-to-face, that is not as difficult. Could we take advantage of that and create some sort of a certain network that people that have, if you identify, we know some of the background of some of our families, can you have someone with a new diagnosis or someone with a question look into the network? We as an alliance try to facilitate that. And obviously also, I will say the last part, and you just to give some time to some other people to comment, is that do we try to also understand the resources at the more local level? If you live in the Midwest, what are the possible places you could go to get support, or what are the kind of things that state have or that particular city? As I talked about this yesterday, for instance, here in Omaha, it's a small community, but they have a group of parents that got together, and they developed this group that kind of quote unquote babysit for you. They have kids, they have the knowledge of dealing with kids with chronic illnesses, and then what they do is that they go to your home and spend some time with your kid. Obviously, it's something that you will have to be comfortable with, but I think at least this give the parent a break that sometimes is much needed.
Mm-hmm. Being in a clinical trial for my daughter has been intriguing in that there is an electronic diary that's a part of that kind of throughout. And last night when I was thinking about this, what could be something actionable? I know that I think it was Every Life maybe, or someone had recently put out a burden of caretaker survey. And I felt it was very robust. I felt it very interesting. And I wondered, could we have some kind of experimental, I don't want to say clinical trial, it's not that, but it's almost an emotional trial of measuring over time, like with an electronic diary, where someone is on their, on an emotional spectrum through a caretaking process, and whether we give that to someone for even a week. And I know that, adding additional stress to, caretaking, definitely not what we want to do, but I absolutely know that there are parents who would take on, measuring or doing in some kind of electronic diary to measure where they are in their caretaking and their state of mind. Are they feeling agony? Are they feeling helpless, hopeless? And it might correlate with, some of the things we're talking about, and give direction on answers. I don't know. I mean, you were talking about
I have a crazy resource. Can I share it with you guys?
Mhm.
That I think will hit on that. So being a preschool teacher, we started implementing, it's called the Ruler, and it's through Yale. And it's very comprehensive on emotions and things like that. And one of my favorite parts of it, and it goes from like infancy all the way up into adulthood. I mean, anyone can access it and can use it. But one of my favorite pieces that they have that's part of it is called the Mood Meter. And there's a bunch of you can download the app and you can do like mood meter check-ins, and there's just so much information around it. But it's basically like a grid of 4 different colors. So it's yellow and red, and then green and blue. And it talks about how all of our emotions are kind of on a spectrum, and it goes with your activity level, or like your activity level, and then like the gauge of happiness or whatever. So it really, and there's so many different, it has the online version and stuff, and the app has like every single emotional word that you can ever comprehend. But I think it does a phenomenal job of creating a visual support so that people can choose, like, okay, I'm really, really anxious, but I'm not necessarily like angry anxious. I have like a lot of built up energy, and I don't know, it does a great job of like visually providing some of that. That way we can kind of start describing our feelings a little bit more and honing in on, okay, how am I feeling? Like, it's okay to be anxious. It's okay to be worried, or, need that. And there's just those little nuances that there's a huge difference between anxiety and worried. I mean, there really is. And then there's even a big difference between frustrated and challenged. Something can be frustrating on a good scale, but something can also be frustrating because you feel like you're just spinning your wheels. So it's something that, like I said, I work with my preschoolers on it, but it's so concrete and it's so easily to access. And I, as an adult, I think a lot of times if I'm struggling with my emotions and stuff, I'm like, okay, what am I feeling? Why am I feeling it? And then, next steps, like, do I need to fix this feeling, or is it okay to be feeling like this? So yeah, that would be my, it's a huge, phenomenal resource, and that may help.
Yeah, I like the idea. I mean, we have to do something that is practical, and I'm sure we can look into that type of resources, because at the end we don't want someone to spend a lot of time doing it. And the other thing will be to try to make something subjective a little bit objective. You can have different scales. I think that would be nice, because that will give you a little bit of a better way to look at it from the scientific standpoint, and try how we apply it and make it practical as well, I think. And also, we need also to work on and you were pointed out to that, Stephanie is talking about, looking into what is happening also with the child, as he grows. I think is also going to be important, that emotional health aspect, because this is obviously something that parents are impact the patient, but also it will be interesting if there will be a place to also understand the sibling interaction and how we can help that, because I think at times that's a major problem for kids with chronic illnesses, is that how the siblings handle the situation sometimes, how we can help the family, what is okay, what is probably too much. And because that have a great impact also in the development of the sibling of someone with a chronic illness. I think we have to kind of look at this in a global fashion as a whole, the whole family, and how can we help the couples also sometimes to deal with this, because we understand the outcomes are either you become stronger out of this or you fall apart. And I think that if there's any way we can help with resources as well, or how to diagnose that, how as an alliance we can develop tools with the help of some of our psychologists or people that we know, experts on those areas, to try to quantify this and recognize this early, and then offer, because sometimes not only the diagnosis, that obviously that's my physician mind, but also how you treat that is how, okay, now you told me this is the problem, but what can you do for me?
Mm-hmm. Dr. Feinstein, you look like you're ready to jump in.
Has anybody thought about trying to do a pilot study with one of the apps, like Talkspace or any of those?
That'd be great.
I mean, the Alliance may want to just reach out to, I mean, there's a couple different ones, obviously. You see the ads on TV all the time. So Michael Phillips is doing one of them. I don't know which one it is, but those ads are all over the place. But maybe if you reach out to the leaders of some of those and just ask about a pilot study, even if you enrolled, a dozen patients or families over the course of 6 months or a year, even being able to track whether they can check in with them consistently would actually be pretty interesting, right? Because the barriers to getting there are as low as they possibly can be. So even doing something as simple as that for 6 months or 12 months on a consistent basis may actually provide a ton of relief, or prove in fact that that is not even possible.
Right. That's a great idea. I also, in the interim, like the idea, Dr. Kieris, you talked about maybe a survey or something, but even an annual emotional well-being questionnaire, on a visit as well. I'd like to pull in Lauren and Mosna. After giving your presentations and hearing the feedback yesterday, and then now today, what are your thoughts and ideas surrounding this? Okay. Lauren was here just a minute ago. How about any of the other clinicians, Benita, Kathy, David? What are your thoughts on the emotional aspect here?
Hi, Roberta. I mean, I think there's two things to think about. One is if we are interested in an academic standpoint, do we characterize it? Are we interested in studying the emotional aspect, the emotional burden of ALGSA syndrome? And then the purpose of that would be to characterize it, study it, publish it, and then that would inform healthcare professionals. That's, I think, one point. But then but while that could take a while, and as part of the GALA study, we didn't talk about it for time restraints, but we are going to do a systematic patient-reported arm of the study. You may remember you reviewed those case report forms, and we're going to use validated measures to do that for adolescents and young adults. So that's one piece. But then the other part is, if you separate out studying it and understanding it, characterizing it, is in the meantime, families or individuals clearly need support. Right. And so I would say you have, and you should continue to charge us as the academic community to learn to study it. But the support part, I think, comes from from the Alliance. And hopefully, if we study more and learn more, we will inform you. We will help our work will be able to inform support mechanisms. But almost at this point, because we haven't properly studied it, the support mechanisms are going to be very generic. And I think that's okay. And then as we learn more, we'll be able to have more specific support mechanisms. But right now, I think we know our families are suffering, and we know that there's a burden. I would throw the whole toolkit that you have in terms of support mechanisms, all the things that you're suggesting. And then over time, we can refine those approaches as we understand things better. So certainly as part of GALA, we will have a patient-reported outcome study using validated and systematic measurements. And I hope that those data in a year or two, we can report them back to everybody. But in the meantime, I think I would move to you in the Alliance. I think you need to find, honestly, a psychologist who treats patients, who's willing to help share some of their knowledge with you guys, and then to partner with the families.
Yes. We do have, we do have our support groups. Again, they're not moderated, but they give a tremendous amount of support. Through our ALGSA program as well, we've been able to refer patients to psychological care in their neighborhoods or surrounding neighborhoods. As part of our assistance program, we've considered, can we pay for 2 or 3 or 4 or 5 visits to get the ball rolling on care as well. And we're working through that currently. I do think, with just like the bone pain, with the emotional aspect, I think it's going to be important to have maybe some educational webinars or live Zooms about this topic. Being relatable and having families hear that other families are having the same kind of problems is really important. So I definitely agree, getting these tools that can help now rather than, results a couple years from now is extremely important.
Yeah, and it'll be an ongoing process. We'll learn more, we'll refine it, but you guys need to, it's hard for us right now as liver doctors and cardiologists to know exactly what the right support would be. I feel it's almost like I know that there's a need, but I don't know that I certainly have the exact tools in place, because we can do it in a clinic visit and we can provide support for that amount of time, but that's not adequate for what we're really talking about here, right?
Yeah.
So.
And, to expand a little bit on what Benita said, I think she said very well. I think the part of doing the research is one important piece. I think we need to understand that part much better than we do. The second part of how can we help to immediately, and I think obviously this is an area that it can become a little tricky. One is because it should sometimes, as we were talking, is something that people won't come out and say out loud that I need help. I mean, there are some that will, but not everybody they're very, very sensitive. And sometimes also us as a doctor, sometimes when you start digging into this is that, okay, I found someone that has depression, what do I do now? Then obviously, if you make the diagnosis, going back to that physician mind, then I want to be ready to treat it, or how to help that patient that I just made a diagnosis on. But I think something that will be that something we could do, and it's just a suggestion, is that can we just go and do a survey in a way, or some sort of or go around and try to figure out, in a more anonymous way, or in a way that people don't feel that they have to come out loud and say it. It's like, do we have the need out there right now? What is the need? What are the issues right now that people need help with, that belongs to the Alliance, or we have ties with the Alliance? And then once you understand how many people are there that need help, then try to work with the, identify, Lauren was here yesterday from CHOP, but there are some psychologists that we can identify, each of us as physicians or providers, that if you identify someone needs help close to Omaha, just to make an example, then I will try to figure out what the resources are, or do they just need a support group also to get a pool of, how many of you will be willing to get together with people that may have similar environment, similar disease processes or things like that? Can you get them then together as an alliance? Because that would be a way, like, you identify 3 or 4 people that have similar heart conditions or similar liver problems, or patients that went through transplant with ALagille, and then you try to ask for them with the permission of, can you get together? And then you don't have to meet every week or anything like that, but you can become a resource. People do social media for other stuff, then that's the world we live. People talk to each other at the distance, and then we need to take advantage of that. And I think we can help also in that way. But I think we could figure it out with the help of Lauren or some of the psychologists. I would be happy to help as well. But I think just to how can we identify those needs? How can we create these kind of groups and and become a resource right away, while we're at the meantime also sort out what the needs are in a scientific fashion through a better, well-designed, as Benita has the resources now we got it through GALA, that probably have a larger group of people that we can investigate that, but also at the same time as an alliance, take care of the needs of our parents, our patients, our families, actually.
Mm-hmm. And I think it's so varied too. You know, that's Roberta and I have that. You know, you've got the section of people or the cohort of people who do want to be anonymous, like you said, Dr. Quiros, but then all the way through to, you know, there's one individual that I think between the two of us, we've probably spent, I don't know, Roberta, 20 plus hours with this individual, kind of counseling him through it, and I'm using that word very loosely, through job loss and divorce and just so many different things. And we're not really qualified to do that. We're qualified to, you know, to talk and be, you know, a little bit of support, but it's so widely varied. I'm not sure this particular person would get as much out of a support group or, you know, an anonymous, but then you've got the other side. So we're trying to balance, you know, all of those different things. I wanted to point out real quick before we have to move on. I know you guys are loving all my percentages on the surveys, but I did just want to point out on the main survey, the overall impact. So this was, the question talked about how ALGSA syndrome is more than just a liver disease, and please describe your overall daily life, how it affects your overall daily life. Of the first, it was nutrition, which we talked about. The second thing was itch, sleeplessness, cardiac, but over half said mental and emotional stress for the caregiver. And then half said mental and emotional stress for the patient. And almost 40% said mental and emotional stress for siblings. So we don't want to forget all of the, you know, the rest of the family that is impacted. You know, I hope that we're able to send out the survey in its entirety to everyone to see. It's just, every time we go back and look at it, something else jumps out at us and we say, oh, write that down. Let's not forget that. So I just wanted to mention that it's stress for caregivers, patients, and also siblings. We're just about at time to move on to the next one. I want to stay on track if we can. Is there anything that Dr. Quiros or Roberta or did Dr. Fessner get back in?
No.
I just wanna just make one last comment. Perhaps we should identify 2 or 3 professional psychologists that could help us to sort this out a little bit better. And the reason being is that I can guarantee you that what you described, sure, I'm sure that that's what happened in a community of people, different people with chronic illnesses. And I think I think that will help us to be prepared for those situations that you just described that you spend a long time on.
Mm-hmm.
We are connected now to Dr. Fessner, but if any of you have psychologists you think, you know, that would help us, let us know, and we would love to be connected with them also. I do want to also say, you know, thinking about some of the stressors that add on to the emotional aspect, it's a lot of times financial burden, which is, you know, very difficult. And, you know, even though Cher and I talk to a lot of families, what we are really good at is being resourceful and trying to find ways to help them. So, you know, we have our assistance program, but we also know of other organizations that have assistance programs, and we you know, make sure that we're giving them resources that are actionable, as well as like the nutrition piece is a real issue. Education piece, now that COVID and the pandemic is going on, our families are now forced to also deal with ALGSA and be teachers. So we've been able to help them with an assistance program to offer educational, you know, financial assistance and pay rent and or mortgage to help them with that as well, and Wi-Fi bills. So any of those resources, if anyone knows of any resources like that, that we could, you know, just put on a resource list to offer the families that would help alleviate some of that extra outside stress, definitely send it our way.
Okay. All right, no breaks, almost finished. I'm going to turn it over to Dr. Kamath and also Tara to recap itch. I'm actually going to let Tara start that off.
So our itch conversation yesterday, we had a little bit of everything. Dr. Kamath gave an overview of the itch in cholestasis. Something that was definitely interesting was the factor X that she talked about. There's something missing in our information, who itches and why and how much they itch. Ed Tucker and Ron Cooper from Miram and Albreo gave their prospective drugs and development updates, which is always very hopeful to anyone who has a child with itch. It's always great to hear that someone has an interest in bringing relief to the community. And I talked a little bit about my monkey cord, and there's always so much we can go into with itch, from actual treatments to, like we were just discussing, about the, you know, emotional support for caregivers. So that's just a quick overview of what we talked about.
Okay, good. And Dr. Kamath, can we move into some of those action items that that we wanted to look at going forward? Let's see, I'm gonna pull up.
Yes, we were talking about tangible resources needed to bridge knowledge gaps.
Yep.
Right. So I mean, there's lots of tangible resources, right, that we could develop. So I mean, I think first of all, the issue is I think that's one thing that's really important is that even if you have a patient that's diagnosed early, is to even warn the families a priori that itching could be a problem, right? I mean, we know that the itching is awful, and there's a number of things that we can do, and we can discuss what we can do. But I think one of the key things is that I like to almost even prepare the family. I don't think you can ever really prepare people, but to say, this is something to watch out for. This is something that can happen. And then once we're in it, in terms of tangible resources, I mean, I think the list of medications that we have that are currently available are fairly limited. And that's probably, that information can be on the Alliance website. It's certainly also available in various, it's a very simple table, right, about what we currently have. And it's available in many review articles also. So it would then be, if those types of review articles that have a nice table of the medications that we use is available to families, and if families felt that they weren't, as it were, being moved up the sequence of those medications, that they could just print out that table and take it to their doctor and say, look, I got this from a review. This is a table, and the doses are on the table as well. We can't make it any easier for you. Is this something that we can use? So I think that sort of, you know, having a whole review article for people to read through can be challenging, but even just having a table of medications with the doses, and that's available in multiple places. We can even make that up and just modify it slightly so that there's no copyright issue.
Okay.
And make that available. In terms of information about the clinical trials, the key about the clinical trials is that even if you have information, a resource about the trial from the company, it's going to depend on whether the site where you're at is participating in the trial.
Mm-hmm. Yeah.
So, you know, and so, but then the question is, I don't know, and I'm not sure who's left on the call at the moment from Miram or Albreo, but is it, can let's say a family's in an area where they don't know if their site doesn't, but there might be another site nearby. I suppose they could contact any of us in the Alliance and say, what would be the nearest site that has a clinical trial? I'm not sure if they're allowed to contact the companies and ask them what the nearest site is that has an open study.
Mm-hmm. Looks like there's several, you know, with the expanded access, you know, so that for Miriam, at least, that's a little bit easier, at least here in the U.S. and Canada.
Yes.
But as far as, I'm not sure who's still on from Albareo.
But certainly a family who was interested in a trial could contact the Lions and then get to us, and we could say, okay, you live here, you're X number of miles away, it's going to be feasible, it's not going to be feasible, but to get a family into a trial. I mean, we know which sites are open. This information is all available on clinicaltrials.gov. It's available on the company websites.
Right.
But if a family was really motivated to get into a trial, we could potentially connect them. Of course, the first thing is to do is to ask at your own site. But if your own site isn't available, there may be a site near.
And I think it's good for us also to, and we went through it yesterday, you know, to really help the community understand the differences in the two companies, the two medications that are out there right now are becoming available. You know, that's because there's always, you know, a family just hears, hi, Santiago. Hi, Santiago. There's, you know, there's always that question, you know, a family just hears, you know, an itch medication. And so I think being able to point out, and, you know, they both touched on that yesterday. So I think that's important for us too. Again, more communication. I think Jessica Savage from Albareo. Jessica, were you able to get your audio on? She was having some, okay. That's okay. And then also to Dr. Kamath, if you could just, you know, as far as that factor X that you talked about, you know, it's that's going to be talked about, you know, I mean, everyone that listens to it is going to, what is that? What is that? You know?
Yeah, I mean, it is so, when the studies came out on LPA and autotaxin, it's about 5 or 6 years ago, we really thought that those data came out from Europe, and we thought that was going to be factor X, and there was some nice correlation between itch severity in mice and in adult women with cholestasis of pregnancy. We thought this is going to be factor, and it hasn't turned out to be the smoking gun as we thought it was. So I still think that there is another agent out there that's probably related to bile acid metabolism, and it's related to LPA that we still don't know about. And so we will keep looking. We're currently thinking about, we're starting a collaboration thinking about the role of the immune system and whether that could be interacting in itch, because certainly in other, what we're thinking now is like to think outside the box. If in the cholestasis world, we haven't identified factor X, so we have to go outside the world. So WashU, Washington University, has a whole center for itch. It's called the Center for Itch at WashU. And we've started interacting with them, some of us from the to try to, because they don't really think about cholestasis itch, but they think about itch in general. And we're trying to get their expertise to get them to start thinking about cholestasis itch. And they're very interested in the role of the immune system in mediating itch. So that's a new exciting area that we're going to hone in on. In the meantime, though, what's good is that we do have some medications that work, and the IBAT inhibitors really do seem to have a positive response. So even though these new medications or like IBAT inhibitors may not be acting on factor X, clearly by mediating bile acids, they're helping the situation in many patients. So I don't think that just because we don't know what factor X is that we don't have to have hope. We have to do both things in parallel. We have to get drugs going for where we know that we can see where we can see that there's benefit, but in the meantime we do have to keep going, and we will keep looking for factor X, I promise.
Yeah. Over here, so I know Shami is kind of mentioning some things that like you spoke about, Dr. Kamath, you know, alerting parents in the beginning, but what's our best way to communicate that without additional fear? You know, how can we communicate, like Shami, like you're saying over here, you know, some things that are, well, and Stephanie, some things that are shocking and traumatic, you know, we want to prepare, but not cause additional fear. And then also the tips and tricks like Tara talked about yesterday with the different kind of brushes and, you know, things for scratching. How can we best communicate that? And maybe the families can chime in here. You know, how we can get that information to you. Shami's got something, I think.
Yeah.
No, it's essentially yarn. It's just yarn. It's what I use when I'm in my itchy fits. So I just wanted to share that.
But this is what I was actually going to say. Like, as physicians, I can't communicate. This is what I really feel that, I mean, I say, look, itching may become an issue. We need to watch out for it. And I just immediately refer them to the Alliance.
Good.
I mean, it's like my disclosure on my slide yesterday. I haven't lived with it or experienced it in my household the way that you all have. Mm-hmm. How can I possibly communicate that other than to say that I have huge empathy and I see it? But the way Tara spoke yesterday, that's what families need. They need to hear directly, you know, they need to see Cord's kit. What do you call it again, Tara?
His itch kit.
His itch kit, right? So anyway, that's why at this point, I feel like I can give the pre-warning, but I immediately tell my families to seek out peer support.
Mm-hmm. Mm-hmm. Yeah. And I think a lot of that has to do with like the patient and provider relationship. I have had an incredible relationship with Bryce's providers from the very get-go, and I'm very, very thankful for that. So they were very receptive to the itching and the waking up to bloody sheets and, you know, all of that kind of stuff. And they have wonderful bedside manner, and I'm receptive to their bedside manner and what they're saying. And if that relationship, you know, from the beginning or whatever, or if the parent is just in a different emotional state, I mean, there's so many variables that I think impact some of those initial symptom discussions or concern discussions, you know, things like that. And I think it's such a kind of a muddy water because there's just too many variables. Does that make sense?
Well, I do think there's a piece to this where, well, we need to make sure that families understand they have to step up though into a role of not overprotecting and over obsessing over the itch, but like Tara is, you know, she's creating tools and she's advocating for Cord to help himself through this as well. And because what we do see is sometimes in the support groups, the emotional aspect gets so, you know, so deep that the families then they're struggling to even just get through the night. And it's important that we really advocate to help our kids learn to self-soothe, as well as giving them the opportunity to choose a carpet maybe that's rough on their skin to interact in what they're doing to self-soothe. And like Tara, you know, at the symposium, some of the things that she brought into the kids' kit there, you know, like a tourniquet cover, you know, having those interactive things, even as an organization, to pull these things together and offer it like an itch kit to a family really helps the kids get involved in their own self-care rather than the parent bearing all this emotional burden to fix it, because they can't.
I think that. Yeah, I think it's really important when we talk about a new normal. I found it easier to come up with our family's new normal on the medical front with blood work and tests and appointments and things like that. But the itch has taken so much longer to adapt into our new normal, I think, because it just is so, it seems so unnatural to see your child that way, that it's been harder. And if I could go back 4 years, I would absolutely change how we acted when he was in that toddler stage of screaming and no understanding, because it would get to the point where, you know, after so long, there's nothing you can do but hold them, and you're crying and you're saying, I'm sorry, because they're begging you for help and you can't help. And now that Cord's a bit older, we've gotten into, it's just another thing. It's just, you know, I have to stretch my shoulders in the morning. Cord has to have a scratch in the morning. It's just another part of our day and our life now. And sometimes at night he gets mad at his legs, sometimes in the morning we can look and say, ooh, that's a really big scratch. How many Band-Aids do you think that one's going to be? But whoa, that's your most Band-Aids on that. You know, it's really, we've really given him more freedom to let it be whatever part of his life it is that day. And that's made a huge difference. And like Stephanie was saying, things with these guys can change so fast, and it's with them, their mind just changes with everything. And us as parents, sometimes we're stuck on, you know, the last 4 days of what's been going on with them, and it's kind of hard to keep up with that. What I have really embraced the last few years came from a good friend whose daughter was living in the hospital with Moya Moya, and they were admitted for, I believe, 10 months, and there was nothing we could do to really help. And we started this group called No Questions, and I have a few ALGSA parents that do this as well with me. And basically what it is we can send each other a message, a text, a phone call with exactly what we need at that exact moment. And it started when she was in the waiting room waiting for her daughter, and she just couldn't process. And we started this. So every now and then my phone will go and I'll get a text saying, can you research this med for side effects and send it to me? Sometimes I get a message that says, can you do a video of Cord telling me knock knock jokes and send it? Can you know, it's everything, but it's really helped us be able to say what we need in the moment, because we look at these kids and we're so focused on what they need that we don't realize that we need help to get them that help as well.
You know, Kathy really talked yesterday, as well as the nutrition piece. It does that same psychological, you know, rabbit hole with that itch does, where a parent can become so over obsessed in trying to get a child to eat that then it becomes such a negative thing between them. And then the child's like, I've got no interest to ever touch food again.
Yeah.
That really is the same way with itching. And when we started on our clinical trial for Maralixabat at Riley Children's Hospital, our first initial set of interviews that we did, Dr. Molliston and I had talked deeply about, you know, the tools that I had used for Chloe or ways that I would help her self-soothe. And she's like, can you write that up on a document for me? Because I think all of our families need to understand that there is an emotional aspect for parents where they have to get to a point where they're encouraging self-soothing and awareness of ALGSA early, because, you know, a parent can get trapped in this emotional trying to fix it. And then there are, in turn, a lot of behavioral issues. A child or an adult is scared to discipline their child for bad behavior, or, you know, it really can turn very negative emotionally for both. And we see the ramifications of that a lot in our support groups, where the children have not been disciplined, where they're not, you know, so they're running around misbehaving or not doing what they should be doing for their homework. But a parent is too scared to address it. And how do we advocate for that early? And so I think pulling something together with those kinds of permissions, for one, to allow parents to say, look, this, just because they're itchy doesn't mean you stop, you know, parenting or disciplining or helping them learn how to handle things on their own.
And I can say that is a global child with a disability issue. Like,
yes.
Because I mean, even like from teaching and from my experience and as a provider and all that kind of stuff, that is an across the board parent-child relationship issue with any child with any kind of a disability, or children in general. If that is as broad as I can possibly make it. I mean, within teaching and stuff, and even with the kiddos that I serve now, there are so many times that I have to have a frank conversation with parents and be like, listen, if you're allowing your 2-year-old to hit you because they have Down syndrome, or they have, you know, possible autism or whatever, or a language delay, or, you know, you name it, that's not okay. Are you going to be okay with them being 18 and still hitting you? Because that's what you're setting up. So that, I think, is just a huge developmental and parent shift. And a lot of that comes from guilt. Parents feel bad. Oh, well, Bryce is suffering. Bryce doesn't know any different. That's his, you know, he has a cool scar. Like, I don't owe him anything and it's not going to make it better. If I give him candy every single day, it's not going to make up for the fact that he had to go through a liver transplant. Like, those two things are completely irrelevant. But I think a lot of times parents feel like they have to make it up to their child, and it's just a mentality shift, and it's a societal shift too. And I always tell my parents, like, the best thing you can do for your kiddos is to hold them to a high expectation so that they grow up to be a decent human being, no matter, like, across the board. So yeah, I definitely think it's a thing that, you know, is challenging to ALGSA families, but that's across the board.
Well, I really liked the idea that Kathy had about getting, you know, like a behavioral psychologist involved in the itch portion, because, you know, it starts with the parents. And if the parents are too scared to parent or advocate to their child to, you know, get on board with this because it's not going away, what can we do here? Pick out a carpet for your room, pick out a tool. You know, my daughter had a canvas laundry basket, and she would dig her hands and slide it around the edge, and we took that thing everywhere for years. You know, it's how can they be okay with getting their child involved very early on, but also have the courage themselves to stand up and feel confident that it's okay to discipline, it's okay to, you know, get through this problem today and we'll start again tomorrow. And we see it's a real struggle for a lot of the parents. And sometimes, you know, like Tara had said, it can take years to get to that point where they're like, okay, I guess this is staying around for a while. What are we going to do there?
I think that's key too, Roberta, because it stretches further than just giving your child the power over their itching. It's being able to advocate for all their medical things. You know, nothing makes me crazier when a doctor or a nurse comes into an appointment and they speak directly to me. They don't look at cord, they don't introduce themselves. And it's been important to us from day one that he is a member of his healthcare team. It's not just me and the doctor that are trying to do what's best for him. It's his life. He's there. And, you know, itch-wise, he was in junior kindergarten, and I was volunteering that day, thankfully. And I heard one of the little people run up to the teacher and say, you know, Madame Cord's got his shirt pulled up. And she didn't look. She had 5 other little people, and she said, oh, Cord, remember, we're going to keep our clothes on. And I turned and looked at him, and he had his shirt pulled up because he was scratching his stomach. And so I mentioned to the teachers that later that day, you know, this is what's happening. He has no idea his shirt's pulled up. He's in one of these zones. And, you know, we talked to Cord, and from then on, you know, if somebody says, ooh, buddy, you're going to make your skin bleed, or, oh, you know, why don't we go get dressed? He'll say, nope, my pajamas make my skin feel better. He'll say, nope, I have to scratch this. It's okay if I bleed, I'll get a Band-Aid. And, you know, giving him that power has been huge and really helpful in appointments too. I mean, he's called out, you know, new residents that have come into that appointment and said, you didn't tell me your name. Can you tell me your name, please? And, you know, it goes from there. So wherever you can give them power, whether it's just choosing which hairbrush feels good on their leg, that little bit of involving them in it, it makes it less overwhelming and scary for them too, I think.
And it gives them ownership. And And it can start young. I mean, Bryce, he knows the names of his meds. He's only on 2, but I'm sorry, it's the most like adorable thing having a 2-year-old say, Tacro, I take Tacro for my liver. Like, it's adorable. And that we got from Amber whenever everything she was going through with Alistair. She had mentioned how the nurses were so shocked that he, knew the names of his medications. And I was like, that's a phenomenal idea. And so we do that with Bryce, and we tell him why he takes his medicine. And for a while, he would say he took it for his butt because he's a 2-year-old. So that was a fun little developmental stage. But we talk about ALGSA syndrome all the time. We talk about Emma's ADHD all the time. It's a huge goal for us in our house that our kids own their bodies and own what is happening to them, and that they can advocate for themselves. Whenever Bryce was jaundice and bright glowworm yellow, if someone said something to us in a store or whatever, Emma would be like, yeah, his liver's crap, like he's having a liver transplant. And I'd be like, Emma, you don't have to tell everyone about this, and that's okay. That normalizes it, and it takes away that fear piece, because he does have ALGSA syndrome. She does have ADHD. That's fine. That's, just a piece of who they are, but it gives them that ownership, and it should start very, very young. And I think parents a lot of times get scared of that, of being like, oh, well, then they're going to be labeled or any of that kind of stuff. And it's different. It's ownership, and that's important. Sorry, I could go on and on about that topic.
Okay. Shami, super quick, can you just tell us your parents' philosophies here on not giving you an ALGS pass when you didn't need one?
Yeah, so basically I'm a very lazy person, and I was that way even in school. I would get out of homework and say, oh, I have a health condition, I'm not going to do this, I'm not going to write a test, I'm just going to put my head down and sleep. I was willful, and you may not believe that now when you see me, but that's a lot because of my parents. I never got an ALGS pass, and all it took was a teacher, kind of letting my parents know that they're easing off on me, that they're not going to push too hard on my grades or my attendance. And my dad just looked at them dead in the eye and said, why? She's a student. Why aren't you expecting the same thing out of her that you would from any other kid? And they were like, no, she's unwell, she gets tired, she sleeps a lot. I got the telling off of a century that night. We stayed up, I think, way past midnight that night. I will never forget that night. We did all the homework I hadn't done. We did all the test work that I had to study for. And we got solutions for my exhaustion, because I would sleep in class. So we had these little cookies that they would put in boxes, and I was the only student allowed to step out every class, eat a cookie, and come back and sit and pay attention in class. So there was no ALGS pass. My disease was not me.
Yeah.
And it was the same for home chores. It was the same for anything else.
Mm-hmm. And I know, we on the surveys and just in general, we hear parents who struggle with treating their ALGS child differently than the siblings. And so if you can get to a point where, hey, you are going to be held responsible for, the same type of things, I think that's good. I think that has made you a good person, Jamie. You are a strong lady. Okay. Have we saved the best for last? Can I say that? No, I can't say that. All right, Dr. Feinstein, we're going to let Roberta kick off this last section of cardiac, and then after that, we'll have some time for some final questions.
I'm just going to read what Cher wrote me and told me I had to say here. So verbatim. Dr. Feinstein spoke about so much pulmonary artery involvement in ALGS, the different types of diagnostic testing, how to determine the appropriate surgeries, as well as facilitating a second opinion in conjunction with your current care team. And Dr. Feinstein, what else? That's all she gave me.
I'm waiting to hear what else you have.
That's it, man. That's all. It was a quick 2-liner.
Nah, so I had sent some stuff out to whoever sent the original email. So
Yeah.
the first part was tangible resources, and I'm just reading my email. Sorry for not looking at the camera. And I said, we should probably put together a how to work up the PA abnormalities in ALGS syndrome, and then have 1 or 2 of the figures that come out of that sort of document as resources that the Alliance could have available. And as I said in that email, we've been actually thinking about doing this for quite some time and haven't gotten to it, but obviously we need to do that. So that was one of the resources I think that would be particularly helpful for families. You know, even if it's just some version of the summary that says, if by the way somebody tells you you have, you know, mild disease, you might want to look a little bit further. We actually had a kid just came across my desk this morning, was a 6-week-old, originally sent in for evaluation, and they noticed that one of the pulmonary arteries was a little bit narrowed. A year later, they sent him in to get a hole in his heart closed in the cath lab. And when they went to the cath lab, they found that the pulmonary arteries were all narrowed and that the pressures were quite high. So even, you know, sort of simple things like noticing that the PAs are smaller and thinking more about maybe there's a reason for that rather than just, you know, it's a normal variation. We should have that out there. Interactive opportunities, just a gigantic shout out to Shannon and Benita and GALA. I think, you know, obviously my favorite part of Shannon's presentation was that she talked that we needed to know more about the cardiac stuff. And she's right. I mean, we really know very little. Sitting here in, you know, our own little world, we see a ton of it. But again, that's mostly because of the surgical stuff that gets sent in. We have no idea what else is out there that we don't see. We just got a paper accepted, should be out in the next couple weeks, in JPEDS that looked at 50 or 60 ALGSA kids that got operated on here. And interestingly, they were sort of divided, as you would expect, in the 3 major categories that I talked about yesterday, just the branch pulmonary artery stenosis, and then the tetralogy, and then the tetralogy with the MAPCAs. And it has, you know, a good look at outcomes. And, you know, I don't want to toot our surgeons' horns, but the results are absolutely incredible when you see what these guys are working with and what they end up doing. And I think, to me, that sets some version of a benchmark for what other surgeons should try to attain. And so I think getting that out and getting the GALA data out will give people more of an idea of what can be expected. So I think that's huge. The other thing that I mentioned actually tacks on to something that I think, Roberta, you had mentioned earlier this morning, which was the possibility about case presentations. Even if they're done quarterly, you could just choose a topic each month. It could be itch and, you know, sort of the stages that somebody went through to try to quote unquote treat or deal with the itch. One could be a liver transplant and what that process is like. One could be, you know, cardiac workup and surgery and what that's like, just to give people a resource so they may know at least a little bit about what they may be heading into, or that their particular case is no different in a large extent than what other people have gone through. So having a couple of cases up on the website may be helpful, and those could either be 5 or 6 different ones that capture the basic concepts, or they could be an ongoing series where you put, you know, whatever, 3 or 4 up each year, and people who care for this, or you could direct residents or fellows to that website to get a better idea, just to get some education out. And then there's just 1,000 potential research ideas. I sent an email to David this morning about some of this stuff, but, you know, one of the things that quite frankly we should be held accountable for, we being us out at Stanford, who get a ton of kids in the operating room, is for us to better understand a lot of the questions that were asked yesterday. You know, why are the vessels so friable? Why do these kids have bleeding issues? Why do these things restenose? I would say that we have a new surgeon who's actually very interested in this and has started working with us in a couple of these different areas. That's Dr. Ma. And so the ability for us to get tissue and test that tissue and be able to better understand this is one small area that we should be working. And then the other stuff we're doing, my other hat is I'm the pulmonary hypertension guy, which is why I love pulmonary arteries. And so one of the things that we've done is we've started treating all of our patients with MAPCAs, for example, with a standardized regimen of pulmonary vasodilating therapy. We have literally no idea whether this is the right way to go to get these vessels to grow. But since we're doing it in a consistent way over the next year or 2, we should theoretically at least have some preliminary data. But realizing that the ALGSA kids have some of the toughest PAs to deal with, this is the group that we should spend a ton of our effort on trying to figure out how to get these vessels to grow. So that's just a little bit of stuff that I thought about, and that's in the email, so people have the notes.
I think it's apparent that we need to schedule a Zoom with your team, live Zoom for families. Yesterday, there were so many great cardiac questions, and I would love to get one scheduled with you guys. I know we've been talking about it through email. Along with that, the interactive portion of the website that you brought up, when we had a call before, you told me you guys had it. I had no idea. And I think those, when it comes to liver transplant and also biliary diversion and cardiac involvement or surgeries, those interactive pieces about the surgeries and what happens, when we share those, they're among some of our top watched and engaged posts. People want to know what they're looking at, what they're facing in the surgery itself, what happens. And any of those things that we can create or, walk through video of some sort are amazing. And I don't know if there's opportunity to pull out some of these different, abnormalities and how you treat them in an interactive video that would be doable. I don't know. I know you have the one. Do you have multiple on there too?
That's the major one that we tend to do, since so many people come for the MAPCAs. I'm happy to double back with the team and ask them if they would consider creating other ones.
Yes. Okay.
Roberta, can I make a comment about the research side? So Jeff, hearing you talk about the pulmonary arteries, it makes me think, as a hepatologist, we always think, oh, the congenital heart disease is already set in stone, prenatally, but those arteries have an opportunity to remodel and grow in these kids. And is this something that we might be able to think about in terms of some of the new research that's going on, trying to look at agents that might modify Notch signaling or target some of the genetic modifiers to just slightly improve JAG1 Notch2 signaling, where we could have better, either growth of new bile ducts or growth of the arteries that are so narrow?
Yeah, I love that concept. I mean, it looks like some of the more significant vascular versions of this may be associated with Notch2. Obviously, that's quite preliminary, and obviously the population of Notch patients is much, much smaller. But yeah, I mean, it would be incredibly exciting if by giving them some version of a therapy, we can call it Notch2 therapy, that we can keep them some portion, wouldn't be probably all of them, but some portion of the kids out of the OR to allow their vessels to grow enough so that the pressures are lower or the flow is better. Obviously, there's a ton of work that would need to be done there. But yeah, we had started this conversation a couple of years ago, but didn't get particularly far. But I think you're totally right. That would be really, really interesting.
But that sort of dovetails in with all the work that's going on with the NCATS collaboration and thinking about developing novel therapeutics that would target Notch signaling, and maybe the heart could benefit from that as well as the liver, potentially.
We would be interested for sure.
I have a question. Can I throw it out there real quick?
Mm-hmm.
Okay, so my son originally, just a little bit of background, my son was originally diagnosed with hypoplastic left heart syndrome in utero. And because of that, and he doesn't have that, but because of that, we were able to, we did his, the cord, umbilical cord. We pulled the tissue and the blood and all that kind of stuff. And we still have that and everything. And I've just always been curious I know that, his genes or half of his genes would have the mutated, the jagged one and all that kind of stuff. But I've just always been curious if there is any, like, we're coming up, well, he's only 3, so we have it for 5 years and then we can re-up and all that kind of stuff. I've just always been curious if there's any, movement forward with utilizing any of that stuff, or if it even has a place with ALGSA syndrome. I mean, he's very healthy right now and stable, which I'm very thankful for, but we have this very wonderful thing that not a lot of families necessarily are able to access. And so I've always been curious.
Yeah, it's a good question. To say that that area of study is understudied would be a gross simplification, right? I think that in general, that area is, and there's two different areas. One is sort of the storage concept and the banking concept, right? And the use concept. And then the second piece of it is actually applying it to challenging scenarios in cardiac and other developmental processes. So I would say that there are clearly people who know way bazillion times more about this than I do, but I think that there are probably people out there who are thinking in these terms. We have a couple new scientists coming to Stanford who are working on building organs or doing repairing organs, and so things like that may come into play. But there's not a lot out there that I am aware of, at least as of right now.
Okay, yeah, and the reason why we were able to, why like we jumped on it for the hypoplastic left heart syndrome is that during the second and third, or especially the second reconstructive surgery that they have to do, the doctors are starting to implement those cells and things like that to start reconstructing to help with the blood or with the heart and everything. And so, which again, I know, if you have a mutated gene, then it throws in a whole nother issue with it. But I've just always been curious. I mean, we're going to hold on to it and it's safe, and maybe at some point it will be used, but I think it's just something interesting for you guys to use in the medical world.
Yeah, I would say one thing I would love to talk offline and just learn a little bit more about the cardiac issues and how they're thinking about these cells, just to sort of start things percolating in my head. I'd appreciate that.
Sure, I'll send you my email and then we can connect later.
That'd be great.
Thank you.
So Dr. Feinstein, as an organization, the cardiac side is extremely difficult for us to support. It's extremely difficult for us to talk about or lay out for a family, or even like, I don't know, answer questions on. It's the worst. We don't even understand as leaders exactly all of the heart complications with ALGSA, what each one, like, what medications go for each one or any of that. Is there a document or something that we can create that lays out all of the different cardiac possibilities? I mean, you had 3 main ones, but are there like 5 or 6 different things that could potentially happen cardiac wise with ALGSA, or I don't know. I don't know what I'm trying to ask, but we don't understand everything. And it's hard for us to support or even educate on this. I think the cardiac piece of ALGSA is the least, the least educated piece of this sometimes. And it's frustrating for us. And then as a second piece to this, Benita had suggested doing a medication list for like the itching, and we have questions. I mean, even here, Sharon Going is asked, are there other drugs than warfarin that can be used? People just don't understand the drugs that are used in the cardiac side, and if there are alternatives.
Yeah, so there's a lot of questions in that question.
I know. I'm sorry.
We need a cheat sheet is what we need. We really
do.
Well, yeah, so I don't want to stick my nose too far in the air when I say this, but there's really a gigantic dividing point. There are what I would consider to be the simple lesions that essentially every good cardiac surgeon in the world can do and do incredibly well. And then there's the subgroup of lesions that sadly the overwhelming majority of ALGSA kids have that are just really, 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 really hard to do well, right? And so, if we want to make up some sort of information sheet that talks about the simple lesions, we can do that. But again, I think the overwhelming majority of cardiologists and cardiac surgeons know very well how to deal with those lesions. Even lesions, quite frankly, like hypoplastic left heart, which is incredibly uncommon in ALGSA, but even so, even those sort of straightforward types of lesions, if you can consider hypoplastic left heart straightforward, I think many centers are very comfortable with. I think the thing that most centers are not as comfortable with are the pulmonary arteries when the involved pieces of the pulmonary arteries are particularly difficult to get to, right? And so, again, nothing against the surgeons. They literally, every single one of them has more talent than I do, but there are surgeons that can work close to the heart, and there are surgeons, and they are few and far between, that can work very far away from the heart in the pulmonary arteries. There's another group actually in the UK, in Birmingham, that has done a fair number of MAPCA reconstructions, right? So, and there's one actually in the Middle East, in Israel. So putting something together that explains sort of what the process is and what it looks like, we can certainly do that. I mean, there's a ton of literature out there documenting Stanford's results, obviously, but it's certainly possible that that literature doesn't get into everybody's hands. I mean, unless you go specifically looking for it, you're not going to find it. So we would be delighted to put together some version of kind of the talk that I gave yesterday that said, here's sort of how we tend to work these up. Here's what we look for. Here's how our surgeons approach this. And here, quite frankly, is our results. This is what you should attempt to achieve. Now, that being said, there's a lot of people out there who can't get to Stanford, right? I mean, that's just the fact of life. And so we can give them sort of a how-to guide, but whether that how-to can actually get how-to done is just a different question. I don't think it's unreasonable to put the challenge out there to show folks what can be done.
Yeah.
Even if it means, even if it means that surgeons from other places come and visit and learn how to do this, or see a couple cases and know what's involved, or, I mean, we're happy to educate. And in relation to your Zoom call, Dr. Hanley has said he's more than happy to do that.
Okay.
So we can certainly put that together. We'll obviously do it around his schedule, but we're happy to do that.
And maybe it's two different. I mean, we want to respect time, but maybe it's two different ones. One that is directed more to families, and one, like you said, that is, maybe for those in the medical field to learn. Just to, so to help them when their patients can't get to Stanford. So maybe it's two different ones.
Yep, we can do that.
Yeah.
Now, on the medical side, if a family is dealing with major heart and they do have surgeries that have to be done, do you feel like any surgeon, a cardiac surgeon, would have the ability to find out, who can do what they can't? Like, do they, we don't know how it works on that side. Do they Google best cardiac surgeon? Like, what happens? Because we have a lot of families who are dealing with stuff, and we see the surgeries are not going well, or the worry with the families, and we're, scared to go into the surgery. We don't know how much, experience they have. I don't know. How can someone get a hold of you, or do they know to do that?
So a couple answers to that question, and I'm going to try and put this as delicately as I possibly can.
Okay.
Half of your question would require a surgeon to admit that they can't do something. That's as gently as I can possibly put that.
Right.
A very, very, very long time ago, I was out interviewing for a job as a division chief. And one of the things that I asked was, and basically they said, you can build whatever you want. And one of the questions I asked was, would you be open to sending very, very specific cases to other programs? And the one I specifically mentioned was Stanford and MAPCA's. And they said, no, we can do that here. And I said, no, actually you can't, right? I mean, we know this. And they were unwilling to even consider that. And the thing that's really frustrating about that is, if you think about the number of MAPCA patients that this program would likely see, it would probably be one a year, maybe two at the most. So the unwillingness to give those patients up is in fact a problem. That is just a fact of life. The other sad fact of life, and I think we published on this, either that or we buried the data because it was hard to put that out there, was that any patient that has been touched at another center does not do as well, even if they come here. So if the first surgeons to operate are our surgeons, the outcomes are better than if anybody else touches them and then they come here. We have the numbers to prove it. It's not like it's a small number.
Right.
So again, so getting to the patients early is key. And I would simply say that word of mouth is going to be the best way to do that. The pulmonary artery reconstruction program, the PAR program here, there's a link on the website. Families or physicians can go straight to it. Dr. McElhenney runs that program, and he is on the other end of the phone. So when people call or people send information, he and Jennifer Scheck, they get it, they review it, it's reviewed with the surgical team, and then the decisions are made. Those are done actually fairly quickly. So there is a system in place. It's just a matter of, I guess, alerting people that it exists. And doing stuff
Centers
like
of expertise then would be important, even, you know, in our community, having centers of expertise for the services that you provide.
Yeah, I think that's right.
Okay.
I mean, you know, in addition to David, there's a reason that CHOP does what they do so well, right? They do a ton of it, and they've been doing it for a long time. Right?
You know, when we had a conversation before, Dr. Feinstein, I was interested to learn that Stanford specializes in moya moya. I had no idea, and I don't think our community understands that. Can you speak to that for a minute?
Yeah, I would say one of the things that Stanford is quite horrible at is PR. So we were terrible at actually even publicizing the pulmonary artery reconstruction program until 3 or 4 years ago. But Gary Steinberg has what I think is probably the world's largest experience in moya moya. And he runs the program at what we call the Big House, so Stanford Hospital. But he and his team take care of all of the pediatric cases as well. And I think he does a terrible job of PR. But he has, you know, he's published on hundreds and hundreds of cases of surgical care for moya moya. So again, and you know, the funny thing was we kept saying to Gary, you know, who would you like to be the point person for moya moya for our program? And he kept saying me. And I kept saying, no, Gary, seriously, like who do you like? NP, RN, like who's, no, he said me. So all of our emails go straight to him, which is great. I mean, we love that, but it was a little bit funny to get that back as an answer. I have Michelle, and she's clearly my boss, but he wanted them all going straight to him. So yeah, so we have the ability to do that, but we don't, quite frankly, publicize it particularly well in the what I'll call non-neurosurgical arenas, and we should be better at that.
And we were also, when we went to CHOP, learned more about there at CHOP, the biliary atresia expertise, and is it muscular, what's with the eye, Dr. Piccoli? Is it or Kathy, the specialty in the eyes?
Ophthalmology?
Yeah.
Oh.
There was one particular thing, and I had asked you about it because do some, you know, ALGSA kids have it? I forget what it was. Macular degeneration or something along that lines. Is that right? But those are the kind of things we don't even as an organization don't know where those specialty places are in different hospitals. And we have, you know, if we have aneurysm or, you know, pain or something, having a document or a resource that tells where the specialists in those areas are, would that be beneficial?
Yeah, I will say that as we created this and we reached out to each of the divisions, I learned a ton. I mean, our ophtho team says that they've now seen a couple kids with what's called optic disc drusen, and that they suspect that may be associated with it. And so our ophthalmologist has gotten the pediatric neuro-ophthalmologist, which I didn't even know existed, quite frankly, involved as well. And so I just think that the more we look, the more we're going to find, and hopefully the more we're going to understand. But I think a lot of us are learning a lot about all of this as we keep pushing forward. And David, I suspect you have the same sort of thoughts on that.
Yeah, I think the eye is a good example of what happens in other organs in the body. The number of manifestations in the eye is actually extraordinary. Drusen is one of the, I would say newer, but I guess it's really like 15, 20 years ago now. But it goes from congenital defects, neural crest defects, corneal defects, acquired defects, retinal degeneration defects. And it really does matter that you have, and some of them are ophthalmologic and some of them are neuro-ophthalmologic. Someone who really understands what they are. And, you know, I mean, there are whole eye institutes in a lot of big cities with major pediatric groups that focus on these things. Yeah, you know, and they're not simple. Those ones are really not simple.
And we have a patient in California whose daughter has retinal dystrophy, and they're looking for a specialist, and we've not been able to locate one. And we don't know how to help this patient, and his daughter is losing her eyesight. We've not seen any research on it. We don't know where to refer her, but we see the same thing with cases like Moya Moya or Chiari malformation or other, you know, situations where we are not even sure where to lead them.
Well, the California one's easy. Just have them email Danielle, the coordinator, and I certainly will not be the one to help them, but we can direct them into the ophtho clinic,
Okay.
and Shannon, and they can either help them get help locally if they have the experts wherever they are, if they're not near us, or obviously if they have the expertise here, they can help them as best they can.
Perfect. Thank you.
The eye is definitely not my world.
And some of that retinal degeneration is a combination of vitamin deficiencies, and they should make absolutely sure that those are more than optimized, like A&E.
It was actually a family whose daughter was in a publication for eye, maybe 10 years ago, was it?
At least. Yeah, it was a long time ago.
So, but now they're at, you know, they're at a dead end road with where to go. And we see that a lot with other circumstances too. So
The first patient I saw at CHOP, the first week I was at CHOP, had a diagnosis of retinitis pigmentosa and was going blind, 18 years old.
This young lady, I think, has already lost sight in one eye, totally, I believe, and now it's the other one. And she's also young, like that, 18 to 24, somewhere in there.
yeah. All right. This is great. You guys, we're so lucky as a community to have such amazing resources here. Just wow.
You know, I would say, you know, absolutely that is true, but it's totally in response to the medical community, to the patient medical community and the leadership that practitioners get excited about this and participate. And so it's a tribute to all of you as a group and to Sharon, Roberta for their leadership. You know, as I said yesterday, I mean, there are literally hundreds of metabolic multi-system diseases, and the ones that rise up are the ones who, you know, start by pulling themselves up by their, you know, bootstraps, whatever that means, I don't know. But, you know, the Cystic Fibrosis Foundation is a perfect example of that. They really took over control of the disease as a patient-based organization that then put expectations and enticements and partnerships with the medical community. So, you know, I think everybody here is glad to be a part of this, because there's, in addition to huge need, which there is in a lot of diseases, there's a great leadership and great family participation. And I think that's what makes these things work. I mean, it really sort of, maybe we're out of sync by like 12 or 16 years or something, but it takes a village. And, you know, when all of these things come together and when you can, you know, marshal, you know, 35 families or, you know, 1,500, 1,800, I don't know if Shannon is still on, but I think the goal for this year should be 2020. There should be 2,020 patients. But the more people that are involved and the more excitement, the more action you get. You know, I think for the first 30 years, we had no, or my first 30 years, we had no interest by pharma because there was no partnership and no incentives. And so there was no drug development for anything. And we were, you know, using things off the rack that had been maybe tried in adults or maybe studied in, you know, 5 kids. I mean, that's, if you look at the papers from 20 years ago, you know, if you say, why do we use rifampin? And you go back and look at those papers, you're like, wow, there's not really great data. So I think this is a tribute to all of you. And, you know, we're glad to do this. I'm sure I speak for all of the practitioners. It's really a joy, but also kind of an honor to partner with you all in this way.
Mm-hmm. Well, we thank everyone so much, but that's the end of our recaps, but we would like to just open it up for any questions and go that route until noon. If anyone can hang in there. I see Lana O'Shea has a question.
I have a question. We started dealing with stomach pains about 2-3 years ago, and they were intermittent, and we couldn't figure out what was going on. And you know, did you eat something wrong? Did you drink too much water while swimming in a pool? And eventually, during one of the ultrasounds, it was they realized that there was a narrowing in the celiac artery. And it became more of a problem going on, and eventually we had a transplant, and that problem was addressed during the transplant. Apparently that artery was so narrowed that they couldn't repair it, they had to replace it. And the more, so a few weeks ago we had a meeting with the similar seminar with the for transplantation. And one of the doctors there said that they actually see quite a bit of this, and in fact, in one of the centers, they don't do live liver transplantation because of this kind of problems in ALGSA patients. And I think he gave a number of about 30% of the patients have this with ALGSA. So it seems to be a very common problem, and we didn't know anything about it, you know, that this kind of things are common in ALGSA patients until we came across it ourselves. And I wonder, maybe it should be addressed, you know, patients should be, it should address the patients earlier in some way, and it should be looked at earlier.
I think we don't have a good understanding of the narrowing of arteries in other parts of the body other than the heart and somewhat in the neck and head. So clearly we're missing some of these. It's hard to know what is the actual number, and then the celiac trunk is actually a very complicated place because there's a narrowing syndrome that is controversial at best. But I have no doubt that celiac artery, hepatic artery, renal artery sometimes are critically narrowed. And it goes back to that question yesterday, should everybody get a, you know, full scan? You know, when you do these vascular scans, you have to be looking specifically at something with sometimes special sequences. But I think it's an important understanding when celiac narrowings in this other syndrome get repaired, the patients only rarely get better. But your son got better with this?
Well, it was replaced during the transplantation.
Mm-hmm. But the pain went away, I mean.
Completely.
Yeah. Yeah. And if they replaced that vessel, then the narrowing was really tremendously critical. So, you know, I think that would be an interesting scan to sort of pass around for people to
So
think.
this was found on one of our routine ultrasounds.
Mhm.
And the person that was doing an ultrasound, he's actually working with companies that make ultrasound machines, and he's teaching ultrasound. So he was incredibly knowledgeable, and he really took time to do an ultrasound, and he accidentally came across it.
Mhm. I mean, there are.
I'll find it and I'll pass it to Roberta to pass to whoever.
Yeah, that'd be great. I mean, when the kidney artery is narrowed, you get high blood pressure. And so that gets screened by pediatrician. In abdominal pain, it's much more of a diffuse process, and many people do for abdominal pain work up the vessels because that's one of the things on the differential. But I've no doubt that on average, the likelihood of a critical abnormality of that is much higher in ALGSA syndrome than in the general population.
There's a question that came through on one of the surveys. Dr. Feinstein, I'll throw this one to you. My child is having cardiac episodes that we are trying to figure out. Any ideas or suggestions would be greatly appreciated. One night, a few months ago, she woke up with extreme racing heart, sweating, nausea, and her arm felt like it was being squeezed. Ever since then, she is having heart pounding episodes that last about 20 minutes. It makes her sick to her stomach, and you can see her heart pounding throughout her whole body, and she also feels dizzy. We're on our third heart monitor and looking for another doctor at this point. Anything we can say back to that mom?
Another heart doctor would not be unreasonable. I mean, and that's not to say that what they're currently doing is wrong.
Sure.
It's sometimes a fresh pair of eyes is always helpful. Again, not seeing any of the data, but certainly hearing about pain that transmits down an arm tends to have us think about coronary issues, right? So if, for example, they're just looking at the actual heart rhythm, in the case of, you know, coronary issues, the rhythm would be normal. It would be faster than normal, but it would be normal, right? So it's not that the heart rhythm problem is the actual issue. It's the response to the other problem, which theoretically could be a coronary issue. But again, with limited data, I would hate to speculate too much.
And way off in left field, if the heart, I mean, like racing heart and those episodic things, I think every cardiologist would identify if you were monitoring, but might also just think out in left field to check the thyroid.
Okay.
Sharon Going had a question earlier about the warfarin, Dr. Feinstein. She said, is there another drug other than warfarin that can be used post-mechanical heart valve? Warfarin has many blood draws, which then adds to the pancytopenia. No.
That was a good pancytopenia. Long story short, I emailed her back privately and just said to send me sort of a question. So our anticoagulation team would certainly be happy to chat with her. There are newer therapies that are out there. Probably one of the bigger ones is something called apixaban. A lot of people are very excited about that particular drug. But again, not knowing which valve and for what reason and sort of the entire history, I'd much rather that the anticoagulation team talk to mom and try and give a real answer rather than one that simply says, yes, there are other drugs that are sometimes used.
Awesome. And then another question is, can either of you, Dr. Picola or Dr. Feinstein, speak to seizures if there's not a diagnosis of, let's say, moya or something additional, you know, what is your experience with seizures? How do you deal with them? What are some of the causes that you may have seen?
Yeah, I think probably both of us have the luxury of sending those patients to the neurologists who take care of those problems. And the causes are really extensive. And sometimes you really just don't find a structural problem or a vascular problem or a metabolic problem. You just have an area of the brain that fires. But clearly some of those things, I mean, you know, we found incidental strokes that, you know, were not clinically evident at the time, but then they make an abnormal area in the brain. Certainly moya, there are other vascular abnormalities. People have minor head injuries that have caused damage. You know, so there's a lot of things, and a great neurologist and great imaging and a specific EEG is the starting place.
Okay.
Dr. Piccoli, there's a question about liver transplant. What exactly determines if a child needs a liver transplant? Is there a checklist? And what are the pros and cons of earlier transplant versus waiting?
Yeah, that is like a 2-hour discussion. But so the first thing I would say is that whenever you consider a liver transplant, make sure you're at a center or you get an opinion where the opinion is balanced between the liver doctors, the hepatologists, the medical doctors, and the surgeons. So clearly, if you go to a center that is totally dominant for transplant surgery and doesn't have much medical expertise, you know, people say, you know, if the only tool you have is a hammer, then every problem looks like a nail, you know. So that has certainly happened in the past with that sort of asymmetric development. So what mandates that you have to do a transplant if the liver is failing? So failing is not a bilirubin thing, it's an albumin, PT, supporting the basic essentials of life. So that's one thing, and for, you know, other diseases, you know, that's fairly clear. It's a little bit more complicated in ALGS syndrome. So you'll find a lot of people who are told your liver's failing, you must be transplanted within 3 months, and then it's 5 years later and nothing's any different. We, a number of centers were transplanting for bone disease at one point, for fractures. A number of patients, and some are appropriate and some perhaps less appropriate, are transplanted just for itching. And you heard a little bit of talk about that yesterday. It certainly alleviates the suffering, the excretion happens, you know. An occasional patient has been transplanted for tumor. That's an important and a good thing to do. Growth is by itself is probably not a good indication for transplant because in fact there are some studies, we talked a little bit about that yesterday, where growth doesn't really change substantially after being transplanted. And certainly there are a number of young adults and adults who have been transplanted who didn't achieve or come close to achieving the growth potential that you would have expected from their parents' genetic heights. So I think it's a complicated decision, and one that you get in Alagille syndrome, you get to think about for a while. Oh, and then of course the other thing is uncontrolled portal hypertension and variceal bleeding, and that is a significant, you know, life-threatening event depending on where you live and how the center has taken care of that. But generally in Alagille syndrome, if you have portal hypertension to the point where you've had significant variceal bleeding, that is not something that's going to reverse. So, you know, as was said yesterday, transplant is changing one disease for another disease. But transplant has become so much better in the last 20 years that in major centers that are thinking about the heart and the kidneys and in your post-transplant care, paying attention to those things, and in the pre-transplant preparation, working very hard on nutrition, whether it's tube feeding or IV nutrition, and screening the other organs. Transplant in ALGSA is not quite as good in outcomes as biliary atresia, but it's way better than it used to be in the early days of transplant.
Anyone can jump in. We do have, I have two other questions that have come in. Hearing loss, is hearing loss connected to ALGSA syndrome? And
Yep.
how?
Yep. And you really want to get tested in the sophisticated ways for hearing. But there are increasing numbers of genetic diseases where we're realizing that hearing loss is an important part of the disorders.
And testing, you testing as soon as possible. I mean, just as soon as you, I mean.
Yeah, that loss in some people is progressive.
Right.
So if hearing is kind of suspect early on, you may want to check it again in a couple of years. I mean, I think we understand, among other things, that the bony remodeling of this whole part of the skull happens throughout life.
Okay. And how can someone donate tissue or other samples? Is there a way to do that?
So that is it. That's a great question, and I guess there are two different ways to donate tissue. One while you're alive, and then one after. So for instance, the Children Network, there are now tens of thousands of biorepository specimens. If you're at a children's center and you enroll in those studies, you probably have already given blood, you may have given liver, other things. When it comes to postmortem, it turns out that it's really hard to do. It seems like it should be easy, and it's easier if you actually die in a major medical center within the walls of the center. But if you die at home, it just turns out to be extraordinarily challenging to do that. And I know people want to do that, just like sometimes they want to do organ or tissue living donation, but it doesn't work. And by the time the tissue is actually, available for something, generally the tissue has started to degrade in a way that it's not particularly helpful.
Katie Temple has a question, but real quick, back to the hearing. Anne-Marie asked, what sophisticated tests are you recommending?
Oh, they start with, an examination and sort of acoustic hearing, but then they can look at the neurologic aspects of hearing. And any major center probably has a huge hearing program at this point, but it's neurologic-based hearing deficits are much more common in ALGSA syndrome, whereas kids with ear infections and fluids usually start and stop with ENT surgeons.
Anne-Marie, do you have a follow-up on that? Is there more than the ABR?
That's a really good place to start. Okay. And probably in ALGSA syndrome, a CT scan, a CAT scan of the head.
That's what we should ask for. We had ear tubes put in, and then we were told she didn't have any fluid behind her. She didn't have any fluid. They did an ABR at the same time, and the results are inconclusive. So I guess the next thing we do is ask for a CT scan.
Yeah, I think so. And how old is your child?
17 months today.
Yeah, I think so. Either a CT or sort of a repeat exam in, 3 to 6 months. Do they feel like there's a significant deficit in the hearing? It's hard to tell at that age because
The whole thing, I actually don't even really understand what the ABR results reveal, but they say moderate hearing loss and then more severe in her left ear than her right.
Yeah. If you send those reports to, Roberta, this is the conduit for things. We have a huge genetic hearing loss program here, and we'd be happy to, not me, but we'd be happy to have the hearing people here just take a look at it and give you some advice.
That would be wonderful. Thank you.
Yeah, a couple of, where's Stephanie? Is she going to yell at me? A couple, well, actually, when we did the ALGSA Family International Symposium right near Stanford, we had all the hearing people there, and they were checking everybody. And Jeff, I will, full disclosure, the reason I'm not a cardiologist in large measure was that my mother said that I was in a rock band and our music was always much too loud. And she assured me that I would be high frequency deaf. And, so while I have a stethoscope, I don't consider it a professional examination. And at that San Mateo ALGSA, I think it was San Diego audiologist did my hearing. And I was right across the board, particularly for my age, 100% all the way out. And I had her sign it, and I sent it to my mother and said, "You may have ruined my life. What do you think?"
Was it Pedro Sanchez that did that?
It was a children's ballet.
What'd you say? Yes, it was.
Pedro Sanchez? Yes.
Pedro, who had been at CHOP a long time ago. Yeah, not that long ago. Yeah.
You know what I just pulled out of that was that you were in a rock band, and I feel like we know what the entertainment will be at Symposium next year.
And what I pulled out of that was that he's a closet cardiologist.
We all get different things. All right, Katie, do you want to ask your question?
Yeah, thank you. My son's had 2 different things happen to him, which his doctors have said had nothing to do with ALGSA, but I wanted to double check. So one is he's had episodes of, is it petechiae, like a sepsis-style rash all over his body, like several times. His labs have been fine, and I was just wondering if you've ever seen that before in ALGSA.
So vascular fragility, blood vessel fragileness, can be a cause of petechiae, and we believe that it happens in Alagille syndrome, but we rarely see petechiae everywhere in someone, and usually when it's there and 3 days later it's going away, usually it's viral. It wouldn't be common, but there is a mechanism where you could connect them.
Okay, thanks. My other question was, he has episodes where his face droops, like I would imagine an adult having a stroke. And I was just wondering if that's something you've seen before as well.
So that's concerning, and we would definitely get an MR angiogram of the neck vessels in the head. But this is drooping that goes away in 1 day.
Oh, yeah, much quicker than that, within about 20 minutes.
Yeah, so that's probably okay. And the neurologists talk about, is the drooping this part of the face, or does it include the forehead?
No, it's like his eye and his mouth, so it's like that.
Yeah, so he should see a neurologist, and if it happens, you should take a movie of it, and with a cell phone, and while you're taking the movie, ask him to smile, frown, raise his eyebrows so that they can see what's happening.
Okay.
There's an anatomic way to get a sense of where this is occurring. Is it in the brain or is it outside the brain based on this examination?
Okay, thank you.
Katie, I've written all that down. I'll email it to you.
Thank you.
Anyone else have a question?
Yes, I do.
Okay.
Can you hear me?
Yeah, we can hear you.
Okay. My granddaughter just turned 1 year old, was just diagnosed about 6 weeks ago with ALGSA. She has left pulmonary vein stenosis and left pulmonary artery stenosis and mild aortic stenosis. She just had a liver ultrasound. It showed mild problem. She is supposed to go in November for a catheterization procedure and balloon dilatation of the artery and vein. I missed the roundtable yesterday, so I missed the cardiac discussion, but I haven't heard anyone mention anything about pulmonary vein stenosis. Is that uncommon in ALGSA?
So yeah, not unseen, but definitely less common than the actual pulmonary artery abnormalities. The aortic valve is also a little bit less common for sure than issues on the right side. I would say that they probably have a little bit of extra work to do before they go, and then depending on what they're thinking, my preference, as I mentioned yesterday, is not ballooning, but it tends to be more surgical. If they want, the other thing is sometimes it's helpful to let things percolate for a little bit unless they absolutely have to go do something, as the pulmonary vein disease may progress or stabilize and other veins may become involved. So it would be sort of a bummer to go in and do a bunch of work only to sort of turn around 6 months later and suddenly see that more veins, for example, are involved. But pulmonary vein disease in ALGSA is pretty uncommon. So I would wait and see what that looks like. Just out of curiosity, was he or she, I missed whether it was grandson or granddaughter, premature at all?
They delivered her early on purpose. They thought that she had hypoplastic aortic arch. She was misdiagnosed in utero, and then they found out she had a corkscrew PDA. And then they found out she has bicuspid aortic valve and the aortic valve stenosis and the stenosis of the pulmonary artery and pulmonary vein.
Yeah, so again, not seeing any of the data. A couple things. Was she delivered very early, you know, sort of in that
3 weeks, 3 weeks early. And that's when they figured out that they thought it was related to the PDA. They just wanted to go ahead and induce my daughter-in-law and before she started having problems because she was doing okay in utero.
Yeah, so the bicuspid valve is actually a very common abnormality in just the general population, not necessarily specifically ALGSA related. And oftentimes that actually needs very little intervention unless it's sort of on a more severe end of the spectrum. So if it's quote unquote just a bicuspid valve, that often doesn't need a lot of stuff. But obviously if they're thinking about addressing it, it's probably more than just mild. But again, I don't have any of the true information in front of me. But unless there's something that I'm missing, I'm not seeing a reason that needs intervention in the short term, unless they think that there's something going on that requires intervention. It's a funny thing to say, but just because you have pulmonary vein stenosis or just because you have pulmonary artery stenosis doesn't mean you need to address it at that particular second.
Okay, she's asymptomatic. She's had a couple episodes of circumoral cyanosis like after a bath, but resolves very quickly. And yeah, she's asymptomatic. So that's interesting that you say that, because they gave us the impression that once you start doing the vein, particularly the pulmonary vein, once you start dilating that might be a frequent thing.
Which is why we don't go touch them.
Okay, I'm
Okay.
so glad you said that. Could my son and daughter-in-law contact you or for some more input about that?
Sure. And again, if the pulmonary arteries are involved, we have a system set up, they can go right in through that system. I'm happy to redirect them over there for sure.
Okay.
I messaged you so you could get in contact with us directly. We'll get you where you need to go.
Perfect. Thank you very much.
Sure. I have a question. How can parents or other family members get genetic testing?
So it's really easy these days. There should be no impediments to this at all. And so I would say there are several different ways, so many children are now tested for free down at Emory. But testing is now pretty standard in many different places. If you know the mutation in your child or in your extended family, then some of the centers allow you to send back that mutation and they give you a significant discount on the testing because you're really only just interested in like that one region or that one exome. But every relative of, every relative in the correct direction. So let's say two parents have 10 kids. If two of the children have ALGSA syndrome, one of the parents definitely has it. But if there are 10 kids, you don't test all the siblings. If both parents are available, you test the two parents. And if neither of the parents have it, then the other 9 kids are not going to have it. Mm-hmm. But once you have 2 children with the disease, almost always one parent has it. But it's not quite 50-50, but about half the time the mutation is new in the child, and about half the time a parent carries it, but they might be totally symptom-free, or they might know that they have some abnormalities. But because of the vascular and the other issues, it's really not right for any insurance company to deny it at this point because it's so important to do. And the testing is available, to probably 50 places in the country now.
Go through your primary care physician or contact?
Primary care could do it. Your child's genetic counselor could definitely set it up for you, and they work out the insurance. So the insurance commonly puts up some resistance. And so those, like we never, that's the one part of insurance we never deal with anymore at CHOP, because we have something called the IMGC, which is, they take care of all the business aspects of this, no matter, for any genetic disease, which in pediatrics is a lot of different things. So, but we do think it's important to know. And, I think one thing that the Alliance has probably rarely touched on is the issue, which is a sensitive issue, but one that has to be discussed, just, like mental health and other things, is the question of genetic counseling. So I was, I think, telling Roberta, I had a patient who came back 25 years later, and he was a kid when he was diagnosed, and he wasn't very sick, and then had 2 children with ALGSA syndrome. And, we missed a window to counsel. Some people don't want to be counseled. Some people absolutely, definitely want to be counseled. And sometimes for parents, it's really important, whether you're going to have another child or not, to know whether, you carry the gene. Other people say, I don't want to know. There are certain genes like neurodegenerative diseases of the elderly where people who are 50 don't want to know if they're carrying that gene because it's a, it's a time bomb. But we have done things like we have participated in IVF, where you can take a cell out of a blastocyst, a fertilized egg, and do single cell testing if the mutation is correct. And amazingly to me, still, the blastocyst is, you know, 12.5 cells. And if you take one out, the thing still is fine and it makes a great kid. And so you can do genetic testing if you can do it reliably on one cell. So we've done that. We do the testing. We don't do the like IVFing. You know, people want to know, could I have a sperm donor? Could I have an egg donor? I want to have this baby, but I don't want it to be my egg. You know, all those different things. Do you do termination? How do you do termination? What's, you know, what are the parameters? I really think it's really important to provide the information. People have their own personal and important thoughts about what they would or would not do. You know, in one of the families where, you know, we did the, you know, sort of IVF sequence, they would not consider a termination, but had a very severely affected child. They did not want to have a second child with ALGSA. And so providing that information, I think, is really, really important, and probably something that the Alliance should consider taking on centrally. Not that they would provide the information, but that they would be the conduit to the discussions around it. Roberta.
On it.
Care.
We're on it.
Yes. You know, I have to say, everyone on the call, that Dr. Piccoli has a passion, like a deep passion, to create a guideline for care for ALGSA adults. And this reproduction and fertility piece is huge. It actually, he agonizes over it. And, you know, together we're going to try to create, you know, a guideline of care for this, because it is so needed. And many of you here have children that are getting to the point where they're going to start questioning, you know, even, you know, my daughter at 16, she wants to know if she's going to be able to have kids or not. You know, Lana, your children are getting to that age too. You know, I think it's important even for our teenagers to understand what are their options, and so they can at least know that having a family is possible, you know. Well, any other questions that we have?
1 minute left.
1 minute.
Parting words, anyone?
Thanks, everybody.
Thank you.
Thank you, everyone.
Bye, everybody.
Bye-bye.
Thanks all. Bye-bye.
Bye-bye.